And I got some really good stuff that some of you can't eat. Like I got the Ostreicher cookies. I got a bunch of those, which are very, very good for IBD patients because it comes in a throw-up bag. So after you eat it, you could reuse the bag. It's called going green. Today here we have a wonderful, amazing, talented group of doctors that will compete to be your doctor. Tonight, we'll see who will answer the right questions, who will put on that look that he knows what he's doing. You know, the wrinkle in his face that he cares so much about you, as if you were his own child or her own child. But anyway, let me introduce, is this wireless? Here we go. Okay, let me just introduce the cast here. Today we are missing, we're missing someone here. I could fill in for them. No? Okay. Yeli, you got my notes? Okay, good. He wanted to like slide it over to me like secretly. Okay, thank you. All right, so we have some people here from CrownHeights, and then we have people here from Williamsburg. Thought it was safe. They're not going to see any of their friends here because they're out of the neighborhood, but you bumped into your neighbor, and your neighbor said, "Oh, I came here because you have IBD. I was trying to show some support." We have some people here from Monroe. We have some people here from Muncie. Anyone here from Muncie? Raise your hand. No? You're here from Muncie? Oh, thanks for coming. Thank you. If you want to speak at any point, for making the schlep here, I'd let you speak. It's going to be a good night here tonight. It's a very tough subject to talk about, and so we will try to make it as easy as possible by throwing in something here and there. If I offend you at all right, so here we go. We have here to my right, we have Dr. Nancy Pittman. Yes. Dr. Rosen talks very highly of you. And he's like, "Oh, Nancy's coming." I guess you guys are on a first name basis. Doctors don't have to call you doctor. They just call you by your first name. Is that it?
That's it.
Okay. So give it up for Nancy. Nancy is a pediatric GI. Yeah, when I was reading in the paper, it was saying how many GIs died in Iraq. I was like, why are there so many gastroenterologists in Iraq? I don't get it. Anyway, it's a joke. All right, and we have here Dr. Simon Lichtiger. Thanks for coming. I know it was not easy. A few patients might die because you're here. And we have Dr. Feza Remzi. Did I pronounce that correctly? Feza Remzi. And we have Dr. David Hudesman. Did I spell it? Was it? Hudesman. Yes, Hudesman. He's a big name, by the way. He's a big name. Yeah, I Google him. And talking about diets and that kind of stuff and like natural stuff. Naturally, you'd have a bearded guy, So we have Dr. Garrett Lawlor. Thanks so much for coming. So we're basically going to try to debate whether it's worth it to go the natural route or medicine tonight. No, I'm just joking. We're not having a debate, And my doctor in Mount Sinai, he has a little bit of everything. He has a dietitian there, a shrink. That was fun. And
of which you use.
Yeah, I use the shrink because insurance pays for it. Why not? And I maxed out, by the way, I'm really happy. I maxed out all my, co-pays and what's the fancy word for you got to pay? Deductible, thank you. So I maxed everything out. So now I'm trying to go to as many doctors as possible because I don't have to pay anything now. I'm like in free mode until January 1st. Then I got to start paying 30% and all this shtick. So I'm getting everything checked in my body. It's amazing. And I'm going to like the shrink every day. I'm discovering new things about myself. All right, so we're going to start off here today with Dr. Hudesman. And Dr. Hudesman is Director of Inflammatory Bowel Disease at the Tisch Hospital, which we all know is the NYU Langone Medical Center. And he went to school for many years. He practiced for how many years have you been practicing? Huh? About 5 years. Well, practice makes perfect, you know. I hope that you will get there one day. And so he's going to talk to you today about IBD, and then we're going to go to the next person. Now, the main focus here tonight is you. We're going to get to your questions, and we're going to have a discussion. So the speakers are not going to speak for that long. They're going to speak until it gets, there's no more information left to say. And then we're going to go to the questions and answers, and we're going to try to get you to leave this place with more knowledge than you came in with. And besides for more knowledge, I think it's just great having fellow IBDers and family of people with IBD. Although I put out a lot of cheers here because I thought we had more people suffering from IBD in this neighborhood, but I guess we're doing good. I guess we're doing good. Thank God. All right, Dr. David Hudesman, thank you.
All right, so I want to thank you, Oli, for inviting me. Happy to be here. So I think I want to keep this talk not too long and really focus on some key topics, and I think we're going to have time at the end for questions. Great. So this evening I'm going to be speaking about optimizing our current IBD therapy, and I think you're going to hear some talks in a little bit about some newer therapies that are coming out. So it'll be a nice segue into that. So first, I'm just going to briefly review current therapies. After that, I'll really talk about different concepts rather than go into too many details about our current medications. Really talk about concepts of treating our patients, something called treat to target. Talk about optimizing our therapies with drug monitoring, and then the emerging therapies, again, someone else is going to speak about in a little bit. So management of IBD has evolved over time from sort of the early 90s to present, where sort of earlier on, we were really focused on symptom control. You would come in, some pain, some frequent bowel movements, we treat the symptoms, you're feeling better, we'd say, great, come back in a year, come back when you're not feeling so good. And over the years, with research, with endoscopic advancements and newer medications, we realized maybe that's not good enough. Maybe symptoms aren't good enough. We don't want to get you better for that first month, that first 6 months, that first year, but we want to make sure that you're feeling well for many years. Prevent complications down the road, surgeries, make sure you're enjoying your life, spending time with friends and family. So our current therapies, and you can see here, the majority of our current therapies are FDA approved for both Crohn's and ulcerative colitis. And the ones that aren't, we probably still use for both Crohn's and ulcerative colitis, and they probably work for both in some respect. For patients with milder disease, we use the 5-aminosalicylates or mesalamines. For people that aren't familiar with those terms, that's something like Asacol, Lialda, Priso, Colizol, sulfasalazine. You see corticosteroids or steroids here, something like prednisone. That's something that we don't love to use. At certain points with severe flares, we might do it in a short course, but there has to be an exit strategy. Somebody that's just repeatedly using steroids over and over again, as some of you may know, not a lot of pleasant side effects, and you're really not going to change the natural history of disease or sort of what's going to happen in the long term. 6-MP or 6-mercaptopurine or azathioprine, one of our first immunomodulators we used for disease, use it in more moderate disease. And now we've had, a lot of biologics and a lot of newer biologics that have been coming on the market. We have our anti-TNF agents. That includes infliximab, adalimumab, golimumab, and certolizumab. Brand names, if you're not familiar, that's Remicade, Humira, Cimzia, and Simponi. The newer medication called vedolizumab or Entyvio, and that was just FDA approved for both ulcerative colitis and Crohn's about 2.5 years ago. And something that I didn't update the slide, but about a month and a half, 2 months ago, we have Stelara ustekinumab that was just approved for Crohn's. So we have sort of a variety of different options now. And I think the trick is, and we don't know this yet, but hopefully we'll learn in the future sort of what medication is going to work for what patient. So moving past the actual details about the medication, the idea about treat to target. So I'm going to briefly describe what that means. I'll discuss why that's important, and then we'll go through what the different targets are, and not only clinical symptoms, as I was mentioning. And then at the end, talk about a little algorithm or a pathway you could follow. So the idea about treat to target, this is something that's been used in a lot of different medical fields besides IBD. So if you have high blood pressure, you have a target, right? A target blood pressure that you want to keep that below so you don't develop heart problems or neurologic problems down the road. For diabetes, you want to keep your sugar at a certain level, again, so you don't develop complications down the road. And we really haven't until recently, until the past few years, really used that concept in IBD. And the reason why this is important, and sort of the first thing I said in my talk was that symptoms might not be good enough. If you look at all comers that come in with Crohn's or ulcerative colitis, initially they're going to have inflammatory symptoms, and that's the graph in the red, meaning they'll have pain, maybe some weight loss, some frequent bowel movements, some diarrhea. And then if you follow these people over 10, 20, 30 years, the vast majority of these patients now develop complications, right? So it's not only inflammatory symptoms. They could develop strictures or narrowings of their intestine. They could develop fistulas or connection from one part of the body to the other. And they may require surgery. When you look at the risk of surgery in Crohn's disease, maybe within the first year of diagnosis, about 10 to 15% of people will have surgery. But if you follow patients out for 20, 25, 30 years, now up to 65 to 75% of patients will need surgery at some point. Again, why are symptoms not great, especially when we're looking at Crohn's disease? So this is from an older study, but the main part to take out of this graph is you see that the dots are everywhere, right? Which means that on the y-axis you have symptoms, on the x-axis is how it looks inside. And you can see that some people might feel great, however, if you do a colonoscopy or an MRI, it looks horrible inside. Or on the flip side, somebody might feel very sick, and you could do a colonoscopy or an MRI and it looks very good. And maybe it's stress, maybe it's infection. So again, the concept is we want to obviously make sure people are feeling well, but we also want to make sure we're treating the disease and we're preventing progression to those more complicated types of Crohn's and ulcerative colitis, and prevention of surgery. And this is just another nice way to look at this. So if you look at the black line and sort of how it's going up and down, that's a patient's symptoms, right? Sometimes you're feeling good, sometimes you're not. And what you're seeing though with the red line is even, each time you have that little blip, and even with a constant low-level activity, there's this additive effect of damage that's happening inside, where over time that could lead to, again, the narrowing, the complications, and the need for surgery. So how can we prevent this, right? So what are our targets to help prevent these complications? So obviously clinical symptoms are important. We want to make sure that there's normalization in bowel habits in Crohn's disease. We want to make sure people don't have any abdominal pain. But we also want to look further. So we use the term biomarkers. These are blood and stool tests that I'm sure many of your physicians have sent on you, whether it's C-reactive protein or CRP, if you're familiar with that, and ESR, sedimentation rate. We have some newer stool markers that might be a little more accurate in certain situations called fecal calprotectin. So we want to make sure those are getting better with whatever therapy you're on, not just your symptoms. And then ideally, we want to make sure you're healing inside. So if we do a colonoscopy, there's active disease, we put you on whatever treatment, we repeat a colonoscopy in a certain time point later, we want to make sure it's healing. We want to make sure things are better. Because if they're not, that's probably somebody that's going to develop those complications down the line. And maybe that's the right time to pivot and switch therapy. For ulcerative colitis, similar idea. A lot of times with ulcerative colitis, we mainly see rectal bleeding, so we want that to normalize, that there's no more rectal bleeding, normal bowel habits, and very similar targets, where you want our biomarkers, again, CRP and calprotectin, to normalize, and we want to make sure they're healing inside. And this is just, and I don't want you to focus too much on the graphs, but this is just some data why this is important, right? So if you look at people, and this was a study looking at patients that were on infliximab, okay, and azathioprine. Some patients were on one or the other, but when they looked at, they were on whatever therapy they were on, and at 2 years, they did a colonoscopy. And if you were healed inside, so that's the white bar, right? If you were healed inside, if you did another colonoscopy and things looked great, whether you were on infliximab or Remicade, whether you were on 6-MP or azathioprine, and you followed them out another 2 years, 70% of the people were feeling great, were off of steroids. Versus at 2 years, if you were feeling okay, but you did a colonoscopy and there was active disease, 2 years later, only 30% of people were doing well. The majority of people had another flare or required steroids. Same thing when you look at hospitalizations. So this was a study looking at a couple of hundred patients with Crohn's disease on Remicade. They did a colonoscopy before they started Remicade, and then they did another colonoscopy 6 months later. And what you could find, what you see here, if you look at hospitalization rates down the road, if you were healed, meaning you did a colonoscopy, and healed doesn't necessarily mean perfect, but a lot better, looking very good inside, 6 months after starting your Remicade, you are much more likely to be doing well without needing a hospitalization 5 years later than if you weren't. Surgery, same idea. You did a colonoscopy 1 year on therapy, followed these patients out 5 years. If you were healed inside, you had a much lower surgical rate than if you did not, if you were not. And we see this, the same idea with this, our C-reactive protein. And this is, again, a blood test that we measure that suggests that there's inflammation in our system. And C-reactive protein or sedimentation rate, these things could fluctuate for a lot of different reasons. You have a bad cold, you have an infection, these could go up. So it's important to take that history as well. But you could see here, again, just looking at the black line versus the dotted line, these were all patients that were feeling well on their current therapy, 14 weeks on their current therapy. And what they did was they looked at their CRP and they followed people out for a year. So 3 months feeling well, looked at the CRP, how are they doing it 1 year? If your CRP was normal in the black line, you were much more likely to be feeling well 1 year later, not needing steroids, not having a flare of their symptoms, versus if your CRP was elevated. And again, these were all patients feeling well at the time. Same idea as I mentioned with surgeries. For hospitalizations, this is an interesting study where they had a group of patients that were feeling great, no symptoms at all, and they just had an elevated CRP. And they looked at hospitalization rates over the next 18 months, and close to 3 times as many people were hospitalized if they had an elevated CRP when feeling well than if they didn't. So again, just sort of bringing home that point that symptoms may not be enough to treat you. Calprotectin, it's a stool marker similar to CRP. Your physicians might be talking a little bit more about that now. We find that in certain situations, especially ulcerative colitis, it might be more accurate. Some people might not have an elevated CRP or sedimentation rate, so we like to use a stool test. So this was a study looking at patients that were on, and this study infliximab or Remicade, and they looked at calprotectins and their stool test and followed them out over a year. And what you could see, so this idea of sustained deep remission, all that means is that you felt great and the colonoscopy looked great inside throughout the entire year. And you could see that at every time they checked the calprotectin, it was great, it was very low. If you had an elevation in your calprotectin, in this study they're using a number over 300, you were much more likely to flare. And also what was very interesting out of this study was that this elevation in the biomarker of calprotectin occurred up to 3 months before anybody had any symptoms. So the idea is if you're following up with your physician, even when you're feeling well and you're getting blood tests or stool tests, and we say, hey, you know what, this comes back a little bit elevated, It doesn't mean you need to switch therapy, it doesn't mean you need, but it just means maybe it's time to investigate further. And hopefully we can prevent that flare symptomatically if we're sort of monitoring you a little more closely. So the idea for sort of this algorithm of this treat to target approach, and again, this is something very common, as I mentioned, hypertension, diabetes, and so forth, is, you come in with your Crohn's or ulcerative colitis, and we assess the severity of that, whether it's colonoscopy, MRI. We put you on whatever treatment, whether it's diet, whether it's mesalamine therapy, whether it's a biologic therapy. And then over those next 6 months, we're going to be checking stool, we're going to be checking blood, we're going to evaluate your symptoms, making sure you're not only feeling better, but that these markers are improving as well. Maybe 6 months later, give or take, we do a colonoscopy and we say, are you healing inside? And what we've been starting to see are the people that are feeling better, that those biomarkers normalize, that are healed inside, not only feel well for those first 6 months or year, but are going to feel well for many years down the road. And when we're checking, if at 6 months things aren't looking so good, maybe this is the time to pivot or do a little more investigation. Is there an infection? Do we need to adjust medication? The last part I just want to speak briefly about drug monitoring. So I don't know how many of you are on sort of immunosuppressants or biologics or know anybody that are on these therapies, but these are, are very good therapies for both Crohn's and ulcerative colitis. We're using them in more of our moderate to severe patients. And, across the board, I would say about 70% of patients respond or do well with these therapies. The problem is they initially do well, but over the next year, 18 months, up to 40 to 50% of people can lose response. So they initially do well and then it stops working. And part of that could be a reaction to the medication. But the other part is that a lot of times your body is sort of building up a resistance to it or building up this antibodies. And a lot of time what's driving that is that we're just not getting enough drug on board. So when we're starting these biologic therapies, for the majority of patients, your standard dosing probably works well. But there's going to be a big group of people where it just doesn't make sense that the same dose of the same drug is going to work for everybody. Some people might need a little bit more, some people might need to be a little bit less. So the concept of sort of monitoring these levels and adjusting them, hopefully we don't have people that initially do well and then down the road lose response. So this was an earlier study looking at monitoring 6-MP or azathioprine levels. And what you could see is all those black squares are on one side of the graph. And pretty much all this is showing was that if you were actually monitoring levels of your 6-MP and azathioprine and adjusting dosing based on the levels, you were much less likely to have flares or develop more symptoms. If you look at some data, this is now looking at monitoring for your biologics or your anti-TNFs. Again, your Remicade or Humira. Now we can measure levels with Entyvio or vedolizumab. Is what this is looking at. This was looking at all comers, all patients on infliximab or Remicade that were feeling well, and they measured to see if they checked your blood test, that if you had actually drug in your system, right? That if you're getting an infusion every 8 weeks, that at your 8-week point when you're getting your next infusion, that there was still drug there, that it didn't already wash out, or your body used it up. And then they looked at what happened on these people a year later. And you could see this dark red bars are a lot higher than the pink bars. And what this is showing where if you had detectable drug, if I had you on a drug, and I measured to see if it was still in your system, and it was still in your system, 1 year later, you were much more likely to feel well, for your CRP or biomarkers to normalize, and for things to look good inside, either improve on your colonoscopy or to heal inside. Versus if I checked a level, you're on this drug, and I check a level and it's low or undetectable completely, that you were much less likely to feel well a year later. So the idea is sort of, again, being more proactive, not waiting for you to feel sick, but to sort of adjust medications. And this is a similar slide in ulcerative colitis. The last one was for Crohn's. Same idea. If you just look at C at the bottom, that's surgical rates, right? So that's pretty impressive. This is a small study, so 55% of your people aren't going to surgery, but the difference is pretty large, suggesting that if you didn't have a detectable drug, meaning we weren't giving you the right amount, you were much more likely to need surgery a year later than if you were getting the right amount of drug. And sort of same idea with adalimumab or Humira. Again, so the drugs we can measure levels are Remicade or infliximab, and adalimumab or Humira. Entyvio we're able to as well. So just to summarize, These are the current therapies, right, for ulcerative colitis and Crohn's patients. And again, there's significant overlap in both. And again, almost all of our therapies we could use in both ulcerative colitis or Crohn's, depending on the situation. I think the main take-home point is that symptoms aren't enough. They're very important, but we need to be monitoring you proactively. We want to see you when you're feeling well. We could talk about other things rather than how often you're in the bathroom, right? And sort of, are you spending time with your family? And have a much more enjoyable visit, as well as sort of do some of these simple blood and stool tests where we could say, hey, you know what? I know you're feeling well, but maybe it's time to adjust things or to investigate what's going on. And sort of that evaluation should be happening at least every 6 months. And then just, we have a bunch of great doctors on the panel from Mount Sinai, Columbia, NYU, and I think just a take-home point, I like to, all my patient talks to, I think for Crohn's and ulcerative colitis, it's really a multidisciplinary. You need multidisciplinary comprehensive care, and you're seeing that at all of our institutions, where it's not only the gastroenterologists, it's our nutritionists, nursing support, social work, integrative services, and so forth. So thank you for your time. I think we're saving questions to the end, but if anybody has something quick, happy to answer.
Thank you. Mazel tov. Mazel tov. I'm just going to take a quick break here before I forget. I know I have it over there. No, I just got an alert that I got to take my pills. A little later on in the program, I'm going to give you a very colorful story. I'm going to tell you my journey with IBD. So you don't want to miss that. But first, I'd like to call up one of the doctors that got the most stars on Google, Dr. Simon Lichtiger. Now he's the director of the Inflammatory Bowel Disease program. That's a lot of colonoscopies and stuff like that. He's seen it all, and he's from Columbia University Medical Center, which I hear is one of the best ones. Your parents must have a lot of nachas from you. But today, I just want to thank all of you guys for coming. I know that this is your job, but coming out at night, schlepping all the way down here to the city, talking to a bunch of Jews. I know that it's not easy for you guys, and it just shows that this is more than just a job for you, and I really appreciate it. Please give a round of applause. Thank you. So without further ado, please listen very closely to Dr. Lichtiger. It's hard to get an appointment with him, so listen.
I think if you could just help me get my slides.
Yeah.
And my mother wouldn't have done as well as you did. That was one comment. The other thing is that talking to Jews, you don't do much of that at Columbia. All right, I am here. Okay, there you go. I want to move some of the slides. Hold on. Could you show me? I probably need some help here.
Yeah, we're in this together.
We're in this together. I want to move. Can you? Could you help me?
Plus.
Go ahead. Oh, there you go. Terrific.
Yeah.
So I want to move this slide over here,
Okay.
and this slide over here, and now I think we're ready. Okay, I actually am not going to stand up here when I talk to you. I have 20 minutes, or maybe 20 minutes, to talk to you about what was thought to be emerging therapies. I must say, I'm at a little bit of a disadvantage. I didn't know there would be a mechitza here. I thought we would have one screen. So I'm going to walk between both screens and, of course, give equal time to the men and the women. And it always, anytime I have to talk about Crohn's disease in 15 minutes, it always brings me back to the story when one of my daughters, I have 4 daughters, the youngest one who always needed help with her homework, I came home one night, and of course, She says, Daddy, I need some help with my homework, and I'm saying to myself, I hope it's math and science, because Mommy's much better at math and science than I am. But it wasn't. It was a book about constitutional law. She had to write a paper about one of the Supreme Justices. And happened to be, when he was still alive, a justice that was named Antonia Scalia. And for those of you who know a little bit about the Supreme Court, Antonia Scalia is a brilliant jurist, an expert on constitutional law, but a terrible, terrible lecturer. And everybody knew it, and the students hated being in his class, but had to be in his class because he's Antonia Scalia. Well, on the very last day of the very last exam, one student on his book wrote, Justice Scalia, if I had 15 minutes to live, I'd love to live it with you. And Scalia reads it, goes back to the class the next day and says, you know the nicest thing, somebody said the nicest thing about me, because I know I'm a terrible lecturer, and I know that you can't enjoy what I say, but somebody wrote that if I had 15 minutes to live, I'd like to live it with you. And everybody looks at this kid on the back row who wrote it. Everybody, of course, in the class knew he wrote it. And he meekly raises his hand, and he gently gets up and says, Justice Scalia, did you turn the page? And Scalia said, no. He said, go home and turn the page. So Scalia, thinking that there was some other compliment on the other side, goes home, turns the page, and on the other side of the page it says, because 15 minutes with you is an eternity. So I hope this 15 minutes will not be an eternity. I chose not to necessarily tell you every single drug that's going to be studied in the next few years. I'll mention 2 or 3 of them. Most of them don't even have names, most of them have numbers. But I chose to talk to you about how we formulate medications for Crohn's disease and ulcerative colitis, or what is ulcerative colitis and Crohn's disease, and how do we take care of it? So the first question that you always have to ask yourself, oh, thank you, Garrett. Oh, thank you. The first question that you have always asked to yourself is, do we really need new drugs? And is there a point in putting all of this effort and all of this money into finding new drugs? And of course the answer is yes, and of course we have to progress. Because those of you who've been through this know that steroids are wonderful but terrible long-term. The newer drugs and the better drugs that we have, which are the anti-TNFs, which Dr. Hudesman spoke about before, which came out and were supposed to be so successful, it took us a few years to know that after a year, 40 to 50% of people lose response to it for different reasons. Some people develop antibodies to it, some people just lose response to it. So the best drugs that we have are effective at a year in 50% of patients. Then there are the immunomodulators, or the immunosuppressants, or 6-MP and Imuran. Well, if you look at the more recent studies on 6-MP and Imuran, you find out that when given for particular diseases, if we're lucky and if we're good, they're effective in 35 to 40% of patients. Not very good. And then if you go back to our new drugs, and if you go back to the drugs that we brought in over the past 2 decades, as all of you know, especially young men, there's a higher risk of lymphoma when patients take those drugs. And not only a higher risk of lymphoma, but a terrible lymphoma that is 100% fatal, that happens to young men. Another reason that we need new medications. And then if you don't have disease that is significant enough or that warrants these kind of medications, well, what do we do for mild disease? Well, we treat with antibiotics, we treat the mesalamines, as Dr. Hudesman says, but those of you who've had, unfortunately, difficult disease recognize that in that context, those mild medications don't work. So the past few decades have been really devoted and dedicated to finding new medications for this disease. Now, what is this disease? and what happens in this disease? Well, if you think about it, for all of you who think that the gut or that the intestine is a foolish organism, it's an unbelievably complicated organ, and it is the most effective and the most difficult immune system in our body. Because think about it, because all of you who hopefully eat perfectly clean food and always are relatively sanitary about the food, 3 times a day at minimum, we're putting things into our gut that have different antigens, different bacteria, and your gut has to be able to accept this. Because if it doesn't accept it, you set up a system where there's chronic inflammation. And you set up a system that is termed inflammatory bowel disease. So that if you look at a very small snapshot of the immune system, of the gut immune system, look at it on the slide, and you see the top part of the slide has lots of bacteria and lots of antigens that float around in our intestine all day. And then immediately below that layer, you see that what the slide says, there's a mucus layer, because God was very, very smart. He created us with a mucus layer that has compounds within it that protect us from those antigens. And the mucus layer is our initial line of defense, and it is up to the mucus layer to protect us from all of those antigens that are entering our system at least 3 times a day. Now, that mucus system is composed of many, many different things. Things that are called defensins, metalloproteases, trefoil factors, all of these factors that go into the defense of our immune system. And only over the past 3 to 4 years have the pharmaceutical companies said, you know what, instead of concentrating so much on the offense, let's do a little research on the defense. Let's figure out how to make compounds that make that mucus layer a little bit stronger. And that is just starting now in terms of the basic science of these compounds. But right under that layer, you could see a layer of cells, and there are millions and trillions of those cells that line our entire 35 feet of gut. And if you think about it, it almost has to be like a perfect set of teeth. Your teeth have to be bonded together, no space between those cells, because if there's space between those cells, then those food antigens and all of those other particles are going to enter into the area below it. And if it enters into the area below it, which should be a sterile area, suddenly you get an explosion of inflammation. So that when we devise new drugs and when we devise new medications, and if you could just do the next slide, what you're doing is you're taking somebody who has a break in that set of teeth, and you could see it on top. That's the arrow where antigens are coming in, and when antigens come into that area below the surface, that's not a good thing. Because suddenly you get the secretion and explosion of white blood cells and attack cells and cells that sound really dangerous, like natural killer cells and all kinds of T helper cells. And once the fire starts burning, it's already too late. So that so much of research over the past 2 decades have been looking at that area and trying to figure out how to minimize that inflammation, or how to minimize all of those compounds that we're talking about that are secreted by these cells. So that white blood cells secrete hundreds of compounds, each of which promotes more inflammation. So one of the things that we've done over the past 2 decades is finding compounds that block the secretion of these compounds and therefore decrease inflammation. And then, of course, if on the left side of the slide, you see that there are environmental factors which affect this, there are genetic factors which affect this, but the bottom line is that once the inflammation starts in that layer, it's like the ever-ready bunny. It never shuts itself off. It keeps on going and going and going. So the next slide shows you exactly what happens within that layer, except over the past decade, we started, if you look at the bottom right side of the slide, you'll see some cells that come out of a blood vessel. Now, those blood vessels don't line the top of the gut. They line the bottom of the gut. And those blood vessels have tiny little holes in them which allow more white blood cells to get out of these blood vessels and then enter into that area which we call the lamina propria, which is the playing field, which is that area where the firefight goes on. And over the past decade, we've done work and new drugs at how to prevent those white blood cells from getting out of the blood vessel. So that not only do you prevent some of the white blood cells from producing new pro-inflammatory particles, but you also block this on the egress, or the white blood cells leaving these blood vessels, and again, getting into the playing field. Next slide. Oh, I put you to sleep already, my goodness. So that, as I said before, these white blood cells produce all kinds of compounds that add to the inflammation. It's almost if you were standing over a bonfire and every few minutes you threw in another piece of wood and another piece of paper. And some of the compounds that these white blood cells make are things that we are now studying and trying to block them. So that if you decrease the amount of those compounds being secreted, you decrease inflammation. So that all of you know, because most of you may have been on it, that one of the things, if you look at the top right, is TNF. TNF is tumor necrosis factor. Tumor necrosis factor is feeding fuel to the fire. Blocking tumor necrosis factor are the anti-TNFs, or they're tumor necrosis factor blockers. There are compounds, as these white blood cells secrete things like, you see IL-12 or interleukin-12, and then right below it, interleukin-23. Interleukin-12 and interleukin-23 are compounds that feed inflammation. And as Dr. Hudesman said, we just had the release of a new drug called Stelara or ustekinumab, which blocks the secretion of interleukin-12 and interleukin-23. Interleukin-6, which is also made, is a fascinating interleukin because interleukin-6 is the only interleukin that goes from the blood to the brain. And it is thought that the reason that people feel so much better when they get an intravenous infusion of a medication is because you increase interleukin-6. Interleukin-6 eventually makes serotonin, and patients feel better. Interleukin-6 is also the interleukin that's responsible for fever. Next slide. So you could see that some of these drugs, next slide. You could see that some of these drugs will get into that firefight, and then here is the drug that prevents these white blood cells from getting out of the blood vessel. Because in order for the blood cell to get out of the blood vessel, the blood cell has to hook on to these spikes. It has to be perfectly aligned, and the blood cells roll down the vessel and get out into the middle of the playing field again. Now there is a medication called Entyvio or vedolizumab that blocks the ability of this white blood cell to tie on to these spikes, and the blood cells can't get out of the blood vessel. It's called an anti-integrin. And over the next few years, you will see several new drugs, all related to trying to block these white blood cells from getting into the playing field. Next slide. So that one of them is, again, it's not a drug that has a name, but it was presented at one of the meetings this year. You could see it's an antibody to MADCAM, which are those spikes that go into those blood vessels. So we're trying to devise all kinds of products that decrease the ability of white blood cells to get into that playing field. Some of it is being done by blocking the process of rolling. Some of it is being done by blocking the process of all of those white blood cells secreting all of these different compounds. And some of it even being done over the next couple of years by taking the defense or the mucus system and making it a little bit stronger. So you can see the different targets that we as a group are working on as a nation of physicians in order to try to expand the use of these drugs. Now, just very quickly, the two drugs that I also wanted to show you. The next slide is a drug that is a very complicated drug, but you will hear the term a JAK inhibitor. A JAK inhibitor is a drug that gets into the actual cell and blocks a certain compound or enzyme called the Janus kinase inhibitor. The Janus kinase inhibitor is within the cell, and it sends a signal to the nucleus of the cell or to the motor of the cell. And what the JAK kinase does is it stimulates the production of all kinds of DNA that makes all of these inflammatory compounds. These JAK inhibitors, meaning that it doesn't allow that enzyme to work, doesn't allow the nucleus or the motor of the cell to make more of these compounds. And you will hear about JAK1, JAK2, JAK3, because there are several different JAKs. The one that is presently ending its trial and will be a very, very important addition to the treatment of ulcerative colitis. Next slide is a drug that is called tofacitinib. Tofacitinib is at the end of its study now. It is the first oral drug that's going to come out for ulcerative colitis. It has been found to be amazingly effective. In the higher the dose, the better. Tofacitinib is a JAK inhibitor. The only other drug that I'm going to mention in terms of names, because some of them don't even have any names, some of them won't be out for another 4 or 5 years, so it doesn't make any sense to introduce you to drugs that won't be here for a while. But the other drug that you may have heard of that has been written about is a drug called Mongersen. Mongersen is a drug that was studied in Italy. It is a very novel drug. It is also an oral drug. It is a drug that blocks a certain pinpoint chemical in the inflammatory cascade called, it is an anti-SMAT7. It blocks a very pinpoint chemical, and therefore when it blocks a pinpoint chemical, it doesn't affect the overall immune system like something like Remicade. Mongersen was studied in Italy, published very quickly in a very major journal with amazing results. And the studies that are going to be initiated in the United States are going to be starting in January 1st of this year, where we, as well as other groups, will be looking at Mongersen in the studies. So that if you wanted to know the names, the new ones are Stelara, which just was approved for Crohn's disease. The new one is tofacitinib, which will be approved for ulcerative colitis. Mongersen, which is going to be studied. And all of these chemicals like ertolizumab and all these fancy names, which is just a waste of time to speak about, that are anti-integrants or prevent the white blood cells from getting out of the blood vessels. I hope I've given you a little snapshot into what and how we formulate new medications, how they work on the immune system, how they work on the inflammatory system, and whenever we take questions at the end, I'll be happy to answer any questions that you have about this medication. Thank you.
You got that? Good. All righty. If you want more information about anything that he spoke about, you'll have to make an appointment with him and pay for it. Now, I would like to take this moment here to thank a couple people for making this event possible. So far, we got over 100 people. Not bad for the first IBD event in Crown Heights. And yeah, you can clap, you can clap. So first off, I would like to thank Eli Drummer. Eli Drummer has been, is very famous among the people, the Dredeki people in Williamsburg, in Muncie, in the Hamisha world, because he helps cut red tape. He helps a lot of people, and he started this organization, the Jewish Crohn's and Colitis Support Group, and he's helped countless people. Thank you very much. Give him a big round of applause. I'd also like to thank some people here that are here also tonight. Rondell Damalici, which everyone knows, obviously. She is the Crohn's and Colitis Foundation of America's Regional Director, Metro New York and New Jersey and Philadelphia. They give her a lot of states. Yeah. The CCFA is a co-sponsor of tonight. And with her, we have Alyssa Strauss, who is the CCFA's Regional Education and Support Manager of Greater New York Chapter, overseeing New York City, Fairfield, Westchester, Long Island, and Northern New Jersey. Big round of applause here. Thank you. And locally, we'd like to thank our local sponsor, Sunshine Pharmacy, for coming through. There's always sunshine at Sunshine Pharmacy. They wanted us to say that. We'd also like to thank the big drug companies, AbbVie Pharmaceutical, who's out there in the lobby. They have a lot of stuff that your kids could write on. And you can read on Shabbos. And also the UCB Pharmaceutical. And AbbVie created the Humira pen. And they're giving out these forms you could fill out to get an ambassador. I used to take Humira, and I signed up to get an ambassador, and that's someone that calls you, checks in with you, or could arrange for someone to come to the house to show you how to stab yourself with a needle. I remember the first time that I did Humira was during the 18 minutes on Friday, because the package just came. And my kids were yelling, and the house was in the usual chaos that right before Shabbos, and they're banging on my bedroom door. I had the door locked, but it was one of those like cheaper lock that that could easily be broken in. And there I had my YouTube open, and I'm looking at different videos of people showing me how to do it, and then it says, grab a piece of fat, and I'm like, where? I can't. So I don't know if I did it right, but I just took 4 needles, boom, 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 and I just stabbed myself. I think one in the heart. And good times with Humira. Unfortunately, it didn't work, but whatever. Different results may vary. Some restricted supply, ask for details. Coming here tonight, we're going to have an appearance by the local celebrity doctor, Dr. Eli Rosen will come here tonight. Yes? And let's see here, who else? Donald Trump will not be here tonight. The next up, we'd like to talk about food and diets and how they play a role in your IBD. I know that there's a lot of different things that are said about food, a lot of different kind of diets. My mother, whenever I speak to her, she's always telling me about this friend that took this diet or that friend that took that diet, and you should only drink honey for a month, only honey. And then there's the cabbage juice diet, and there's things that really want to make me throw up. So let's hear how diet and natural remedies play a role here with Dr. Garrett Lawlor, who's the Associate Director of the Inflammatory Bowel Disease Program at Columbia University Medical Center.
Good evening, everybody. Thank you very much for having us here tonight. I guess I have the dubious honor of talking about diet, nutrition, and alternative complementary therapies because I think it's one of the more fun things to talk about. But it's also the one that we have the least kind of scientific evidence about. So, I mean, some of it is scientific evidence, some of it is what we learn from talking to our patients about what is most, sorry. So some of it has to do with what the patients tell us, how you respond to specific diets, and how you feel overall. So why is it important to discuss diet and nutrition and alternative therapies with your doctor and dietitian? Well, it's because of what we understand about inflammatory bowel disease. It's not a straightforward thing. It's not that one gene or one bug has caused this disease in the first place. It's a marriage of a number of different things. It's that you're genetically predetermined, that you have the genes that caused this disease in the first place, and that allowed your immune system to be a little bit hyperactive, a little bit too awake and too ready for a fight, and then it was triggered by something, whether it's a bug in your diet or a bug in your gut or something else in your diet or something else that caused this trigger that allowed that inflammatory cycle to occur. So, and we know this. I mean, patients kind of come back to us and say that they feel that diet causes inflammatory bowel disease. About 15% of patients feel that diet has caused their inflammatory bowel disease. Around about 50% of patients feel that IBD changes the pleasure of eating, so therefore they have less pleasure in what they're eating. And about 2/3 of patients avoid certain foods because they feel that a certain food type will actually make their symptoms worse. So what are the principles of good nutrition? Why is it so important that we get enough calories and nutrition in our diet? Well, because it maintains energy, keeps you strong, promotes healing, so therefore allows the disease to heal itself as well. Helps immunity, keeps your immune system going in the right direction, and also medication efficacy. By maintaining your nutritional status, by eating properly, getting enough calories and vitamins into your diet will help medications do their job as well. So it's a two-pronged, it goes in both ways. So how does IBD affect digestion? So it's pretty straightforward. You've got gut inflammation, whether it's Crohn's disease where your small bowel and or your large bowel may be inflamed and involved and therefore not allowing certain nutrients to get absorbed through the gut wall. And then in ulcerative colitis, same idea. You've got inflammation in the colon, so therefore the nutrition is not being absorbed correctly, whether or not it's just spewing through your colon with diarrhea or just that the wall is so inflamed nothing is getting in. Diet appears to be associated with nuances in inflammatory bowel disease. So this is based on a study from back in 2011. Now, it was retrospective, and it's important to try and look at a retrospective study and prove that there's causality, i.e. to prove that a specific diet causes inflammatory bowel disease. So I think you need to take this slide with a grain of salt. But this study did show that specific things, high-fat diets, polyunsaturated fatty acids, omega-6 and meat, may increase the risk of the development of inflammatory bowel disease. Now that's a very strong thing to say. They did find an association, but it certainly doesn't, it has never been proven to be causal. So for someone like myself to stand up and say, you need to avoid this, to avoid having inflammatory bowel disease down the road is a very dangerous thing to say. But it's just, this is the data that we have so far. High fiber, high fruit diets appear to reduce the risk of Crohn's disease, again in this retrospective study. And a high vegetable intake reduced the risk of ulcerative colitis. Again, this specific slide I would take with a grain of salt and just kind of bear these things in mind. It's more like an academic interest piece that this is. But going into when you have inflammatory bowel disease, what do you do with your diet and why affecting your diet can affect the inflammatory bowel disease itself. So this, I think, is the kind of the most important slide. It's got the most information. Everything else is just kind of feathering around it. But I think you can get most of the information on this slide. The things that you kind of, these are the kind of hard and fast rules associated between diet and inflammatory bowel disease. And again, there are caveats to all of this stuff. First of all, diet doesn't appear to be able to prevent inflammatory bowel disease. I showed you a study where there's some data suggesting association, but not necessarily causality. It's not causing the inflammatory bowel disease. Diet cannot provide sustainable disease control without conventional therapy. So in other words, if you go on a specific diet, that it may help you feel better, but it may not help the disease control itself. And this is something that kind of comes back and forth, and something that Dr. Hudesman came up with, was speaking of in his talk. I think when we're treating patients with inflammatory bowel disease, we're treating you along two lines. One is to treat you symptomatically, to make you feel better, to be able to function, live healthily, have a good quality of life, but also we have to treat the disease itself, get the mucosa, the wall of the gut, into a healing process where it can actually do its job and maintain itself and absorb the nutrients correctly. So, and that kind of goes back to the thing that you may feel better, as we were seeing in the slides earlier, but it doesn't necessarily mean that your disease is under control. And just to give you one example, there was one study that looked at patients who were feeling very, very well. They were all great, but they were going for their routine colonoscopies, and about 30% of them still had some inflammatory colitis going on. So just because you feel better may not mean that the disease is under control, and vice versa. You may feel really bad, but the disease actually may be in good standing. So it's a compromise of both, and that's why we have to approach this disease treatment from two approaches, whether it is symptomatic control and treating inflammatory disease. Diet can help symptoms, which we're going to get into now. What kind of diet can help symptoms of abdominal pain, bloating, diarrhea, fatigue, nausea, feeling crappy overall. And then finally, diet should be individualized based on disease activity. If you've got an active disease, you're flaring, you feel really bad, we change your diet a little bit. If you're feeling well, then you can be a little bit less stringent on your diet. And then a targeted nutrient support based on disease location or medications, depending on where your disease is, may reflect the best diet for you. So do the bugs in my gut affect my IBD? This is one of the biggest things that we see, not only in inflammatory bowel diseases, but also across the board in many, many disease processes. How does the gut microbiome, all those gut bacteria in your bowels, affect your inflammatory bowel disease? You've got more gut bacteria in your colon than you do cells in your body. That's what a big, huge impact this has on your immune system. So the host benefits the bacteria. So the host helps bacteria survive in the bowels. Some bacteria prefer acidic environments, so they live in the stomach. Some bacteria don't like acidic environments, so therefore they live in the colon. And they protect themselves by burrowing into the mucus that is on the surface of our bowels. And on the other hand, the bacteria does good things for us. Bacteria help us break down our vitamins. They help us break down carbohydrates and certain types of fiber that we wouldn't be able to break down ourselves. And if they weren't there, then we could have diarrhea, or we wouldn't be able to absorb all the nutrients that we need to have. And just to give you an idea overall, actually I'll skip the picture there, but just to give you an overall idea of how the bacteria are different. So now I don't want you to look at the words, just kind of look at the overall standing. You can see there's a kind of a couple of boxes, there's red boxes and blue boxes. These represent bacteria that are dysregulated in your gut bacteria. So your normal bowels, if you didn't have inflammatory bowel disease, would have all these bacteria. But if you have, for example, in this case, ulcerative colitis, all the ones that are downregulated here, Prevotella and Streptococcus and so on, are downregulated. So there's a little bit of a difference in the gut flora between ulcerative colitis patients and healthy patients. When you go to Crohn's disease is all over the shop. Crohn's patients have a very madly dysregulated gut flora compared to healthy humans. So therefore, we really see that there's a big difference between the healthy gut flora and those of patients with inflammatory bowel disease. Whether or not it is driving the inflammatory bowel disease, or whether or not it is an innocent bystander being affected by the inflammation itself, we're still learning. So we're getting onto this. So what foods worsen my symptoms? Usually when a patient comes to see you in clinic, they tell you what worsens their symptoms. So that's not really something we need to kind of get into too much detail. But there was one survey by the CCFA, of course, who was here tonight. It was an online survey of a large number of IBD patients measuring patterns of eating, what works well for them, what doesn't work well for them. The few things that kind of unfortunately came out of this was that there was no clear, consistent pattern. That patients felt better when they were taking yogurt, rice, bananas, and non-leafy vegetables. So they would often say, well, when I'm flaring, I'm feeling crappy, I would make smoothies, I would have yogurt, rice, kind of a brat diet, a very basic diet. On the other hand, a lot of patients said that things that made them worse were non-leafy vegetables. So spicy foods, fruits and nuts. I think we see that an awful lot. Spicy foods, alcohol, caffeine, certain things made patients feel a little bit worse. But there was also a lot of disharmony. Some things made patients better, and those same things would make other patients worse. So it very much is a matter of tailoring your diet to what suits you. And again, the reported symptoms may be from food intolerances. So that's the kind of key to all of this. That by specifically sticking to a diet that makes you feel better, that's very good to advocate that, as long as you've got a healthy diet on top of that. But it's not that we're treating the inflammatory process within the bowel wall, but that we're avoiding foods that you're just not absorbing properly during this illness. So popular diets we see being discussed in the literature and also with the patients that we see every day include the specific carbohydrate diet. It's a very restrictive diet. It was first devised by a woman by the name of Elaine Gottschall, whose daughter had ulcerative colitis, and she reported that the diet worked very, very well for her daughter, and therefore it gained a lot of momentum online in the media and so on. So, I skipped there. And basically it's like a very, very restrictive celiac diet, so no gluten, and cuts out a lot of carbohydrates out of your diet. The low FODMAP diet, a relatively new diet, used more often in irritable bowel syndrome, IBS, which is different to IBD, of course. Quite a restrictive diet, and it's a little bit complicated, so usually when we're talking about it, we give a handout because it explains what's in it and what's not in it. But it has been effective for, again, symptomatic control, reducing bloating, gas, flatulence, things like that. Then other diets that kind of have always kind of been mentioned online or in clinics and so on. Atkins diet, South Beach diet, Paleo diet, which are very high protein diets, kind of simplified diets. The Weight Watchers diet, which is more kind of a nutritional balancing with your balance of carbohydrates, your fats, your proteins, and so on. And the most important thing that I wanted to kind of come across in this is that they're all very well supported in testimonials, but the important thing is we need to justify why we're doing it. And why we're doing it is because it makes you feel better and helps your disease be more manageable in real life. But it doesn't necessarily treat the mucosal activity that is underlying it. And that's a very important thing, that diets are used in conjunction with, common sense medical approaches and so on. Enteral nutritional therapy for Crohn's is something that is it gained ground in adult GI at least. Now we've got pediatrics here with me, which is going to be very, very valuable. But because enteral nutrition is I think has been far more readily accepted in pediatric GI as opposed to adult GI. Part of it because it's difficult to convince patients to take it. But enteral nutritional therapy is basically a simplified diet, a liquid diet where the foods are pre-digested, if you will. Has been around for many years already. And it uses specific enteral formulas where the carbohydrates are broken down and are therefore easier to, and then the fatty acids are broken down and easier to absorb. Administered often through an NG tube, like a nasogastric tube, where you get a tube down into your stomach and everything is flushed in, but also comes in packets where you can just drink it 3, 4, 5 cartons a day. It could be given where you just take it exclusively, or you take it along with a small bland diet as well to give you a little bit more of a freedom to eat out. And this is one example of the studies that have been done on this. Most of the studies really have been in pediatrics, but this is one kind of decent study from 2006, a little bit older. There have been more since then, looking at 37 patients. Polymeric diet, which is one of these specific broken down diets, versus steroids, and it found it to be equally effective at 10 weeks. So patients felt the same whether or not they were on steroids or they were on this polymeric diet. So therefore, it may be a way of avoiding steroids per se. But also they did find that mucosal healing was better, so therefore it actually helped heal the surface of the bowels. So is there a specific diet? Is there a special diet? The easy answer is no. All of the diets that have been done have been looked at extensively. We've been looking, trying to find what diet could we use to heal a patient without having to resort to steroids or injections or tablets or whatever. And unfortunately, we just haven't seen the data to suggest that any of these diets have a true impact on the inflammation in the gut or the inflammation in the body. But they do make patients feel better. So that's the other side of the coin, but it is an important side of the coin. With the exception of being enteral nutrition therapy, which has been shown in those smaller studies. Several diets advertised specifically for managing inflammatory bowel disease, but most of them have been proven. And the most important thing is just to talk to your diet before initiating such a restricted diet, because restricted diets are all well and good, but often patients end up being low in vitamin B12 or low in iron or so on, so therefore it can create an imbalance in the body. Fiber is important. I'll just almost skip through this, but it's there's this idea that a low-fiber diet would reduce diarrhea, gas, bloating, abdominal pain, and obstruction. And it's true. If someone is flaring, I'd certainly advocate against fiber, just to get things to come down. The way I explain it is that the fiber could be a little bit heavy and therefore creates pressure in the gut, and therefore can cause symptoms of diarrhea, abdominal pain, bloating, and so on. But in reality, fiber is still a very good thing. So therefore, when someone is not flaring, fiber can help in digestion, and it can also help make sure that the right nutrients reach the colon to allow the colon to heal itself, or the small bowel for that matter. So just avoiding fiber when someone is flaring, when they've got an ostomy, so they've got a poop bag, sometimes high fiber can kind of cause a bit of pressure around it, so patients tailor the amount of fiber in their diet to help their symptoms out. And then if they've got a stricture, so if you've got narrowing, if you've got a tight narrowing, sometimes a high fiber diet can cause pain or bloating or obstruction. Probiotics are quite a topical thing right now, in the same way that we're talking about the gut bacteria, the microbiome. There have been a number of studies looking at a number of bacteria, but the one I did mention was the one with the most data behind it. It's a probiotic known as VSL-3. It is a probiotic that it's not easy to prescribe. You can get it online quite easily. But it has been shown to be useful in ulcerative colitis, in getting patients better and keeping them better. So it is an effective way of treating ulcerative colitis, in such a way that patients with mild disease at least could sometimes avoid therapies, like conventional therapies per se. Also useful for treating pouchitis. So pouchitis is patients who have had ulcerative colitis, had their colon removed, and had the pouch created at the backside. Out of interest, BSL-3 is actually a little bit expensive, and recently a patient showed this to me. There's actually a CVS probiotic that's very, very similar. It contains all the same bacteria. So if you're interested, CVS digestive probiotic, it comes in a purple box. Complementary therapies, then, we'll just kind of cut through it a little bit quickly. Curcumin, which is a staple spice in Indian foods. It's been used for thousands of years in Indian foods, and it was used primarily as an antiseptic because it has antiseptic properties. So it would be mixed into the rice and give the rice that yellow feel and yellow texture. Not very tasty. It didn't really add taste to it, but it has kind of continued traditionally in Indian food. So still you see it in the form of turmeric as an Indian spice. It's a form of ginger. It's from the ginger family at least. But has been shown in 2 decent studies in ulcerative colitis to get patients better and keep them better. So that's certainly something that we talk about when we see patients with mild ulcerative colitis who don't want to step up in therapy. It can be effective. Other things that have been shown in very small studies: wheatgrass for ulcerative colitis, aloe vera for ulcerative colitis, and wormwood for Crohn's disease. Now this is kind of another one of those, take it with a grain of salt. These were small studies, they're poorly powered, and they weren't validated with further studies. So therefore, we use these, so I, for example, would discuss these with patients when a patient has very mild disease, they're just not feeling 100% yet, and we don't want to have to step up to more aggressive therapies, and therefore these things are considered. And then other things, excuse me, Trichocereus suis is a type of pigworm that was shown to be effective. It all started when somebody came back from, I think it was, I can't remember the story, was it India? Was it? I can't remember, a patient with ulcerative colitis then came back from India, and he approaches a gastroenterologist, and suddenly his ulcerative colitis was in remission, and it turned out that he had this type of worm, and therefore it was studied, may be effective. The most recent trials haven't been that useful, but it might be something we might see down the road. Then acupuncture, cognitive therapies, and exercise, I think, can be lumped in together. I don't think that breaching certain nerve roots with acupuncture is what's causing relief in ulcerative colitis or Crohn's disease, but I do think it is something to do with cognition, behavior, stress relief, relaxation therapies that have a true impact on disease activity, whether or not it affects your serotonin levels or just calms you down and reduces your adrenaline drive. There's something to this that appears to help. And the kind of the other side of that is patients do see that when they go through a very difficult, stressful period, whether it is family issues or work issues, they tend to have more flares. So there's something to do with stress that we just haven't fully tied down yet. So what do I tell patients of these? When you're feeling well and everything is great and you're doing well and you're stable, healthy nutritious diet, not to avoid any specific food groups because the vitamins are important, and restricted diets all too commonly result in the reduction in the nutrients that you require to keep your body healthy. Fiber may be beneficial when you're feeling well. Certainly, it enhances fatty acid absorption in the colon, so therefore it's an important thing. But when you're flaring, we cut down off the fiber and therefore give your colon time to heal. Less restrictive exclusion diets may be something in the future. We may tap on the magic diet in the future, but we're just not there yet. Maintenance of adequate vitamin D. Vitamin D is very, very important. If you're not getting enough from the sun, your doctor should check it every once in a while to make sure your vitamin D levels are okay. We talk about vitamin D as a way of absorbing calcium and helping your bones stay strong, but we also know it has an anti-inflammatory impact as well, and therefore the low vitamin D levels may possibly have an impact on your disease activity. So when you're flaring, you're feeling unwell, low fiber, but a high calorie, high protein nutritional supplement, whether it's Boost or Ensures. There's a number of kind of nutritional supplements out there in pharmacies that you can pick up, and they help you if you've got poor appetite and you're not doing well to maintain your caloric intake. When you're looking online, very, very important to take everything with a grain of salt. If you ever find something that concerns you, speak with your gastroenterologist to make sure that it's something that you can take seriously. When you see on these online ads, people are talking about that they have a cure. We don't have a cure. I wish we did. We'll get there within the next 10 years, hopefully, but we're not there yet. Beware recommendations based on one study. If they talk about a study, one study showed this, that's usually not enough for us to truly believe that is the case. Lists of good or bad foods, or the whole concept of superfoods now, which drives me insane. Foods are foods. Some foods make you feel symptomatically worse. Avoid them, that's fine. But there are no clear good foods or bad foods in inflammatory bowel disease. Any website that's pushing a product, they're making money for it, so beware always. Researching expert credentials. If somebody is a doctor and they say, I'm a doctor, I got this, if you look down a little bit further, they could have gotten it online in Ireland or somewhere, I don't know. And have the results been published in somewhere that's reputable. But these are things, if you come across something, you see a new nutritional idea or a diet or whatever, it's important to run it by your gastroenterologist rather than going on this route that may lead to nutritional deficiencies. And then finally, things, because we were just, holidays are coming up and so on. If you're going to stay with family or you're traveling or whatever, it's important to try and stick if possible to normal eating patterns. If you're feeling unwell and you're flaring, rather than eating large meals, eat small meals regularly. That will maintain your nutritional intake and create less pressure on your bowels. Keep track of the foods and symptoms that you're getting. If you try a new food and it makes you feel worse, just remember that and kind of take that into account in the future. And then, of course, the easy thing is just bring food that you like, so that if you're not doing well with the food in the place where you're visiting, at least you have food for yourself. That's it from me. Thank you very much.
Thank you very much. Thank you very much. Now, you said a lot of times, take that with a grain of salt. Did you mean that literally? You should always take grains of salt. You should be careful when you talk about diets and throw in the grain of salt. And, God has a dark sense of humor, He gives the chosen nation this stomach thing, and then gives us holidays like Hanukkah. Let's eat everything deep fried, everybody. And then Shavuos. Let's have everything dairy. And then Pesach. Forget about Pesach. Anyway, without further ado, I would like to welcome someone to the stage that has helped me for many, many years, and through a lot of stuff, and someone that is extremely hard to see and get an appointment with because he is a local celebrity doctor. Please give it up for Dr. Eli Rosen.
Mendy, good job. Thank you. Thank you. Dr. Lichtiger. What can I say? I take care of a lot of patients with colitis. This crew of people over here helps. I'm a big believer in holistic medicine. Which means that as much as you take care of yourself, as much as you involve in your own care, as much as you get your physician to participate in your care, you're going to do well. There are no secrets to this. There are a multitude of different treatments that I'm sure the experts have given you today. For us, on the local level, the treatments are explosive. I don't even know the names of half of the drugs that are coming out every single day. Gone are the days where we had a few drugs that we tried on all the patients and failed most of the time. We're in a new era. And I want to thank everybody for coming. Thank all of the particular physicians who've at various times had to do with sick patients and help them out. And please continue to do so, guys and girls. Thank you.
Wow. Short and sweet. That's never the case in the waiting room at Dr. Rosen's office. Sweet. It is sweet. I gotta tell you, it's sweet. Not really short. Now, tonight, I'd like to talk about my story. They told me to take a break from all the medical talk and talk about personal stuff, just to wake you guys up a little bit, okay? So my name is Mendy Pellin. When I was just finishing up Smitha, I realized that I've got something going on in my gut. I was about 20, 21 years old, and it was pretty frightening. It was pretty frightening because I just thought that there's colds and there's yenemachla, which in medical terms is, you know what that is. I can't say it. Just, you know, poo, poo, poo. So I just figured, you know, if it's bad, then, you know, it's meant to be, and hopefully it'll just go away. But it just got worse and worse and worse, till finally I went to, not Dr. Rosen, and he said that you gotta really, we gotta check this out. We gotta check this out, and we gotta send a camera in. And I said, no, you're not sending a camera in. No. But he said it's very important. So I went to get a colonoscopy. And I figured that every office is like Dr. Rosen's. And if there's something bad, they call you. And if it's okay, then not necessarily. You know, no news is good news. So I didn't hear anything. So I went on for about 8 months, and it got worse. Very, very bad, until finally I went to the hospital, and they said, what are you doing, what are you on for your ulcerative colitis? And I said, the who? Like we see on your files here, you have ulcerative colitis. And that's how I learned that I had ulcerative colitis, so I just said, okay, just give me some kind of Advil or whatever medication to just get rid of this thing. And they're like, no, you've got this, It's not going anywhere. And it took some time. I didn't really, you know, as a kid, you think that you get sick, you take some either ichi or not so ichi medicine, and you get better. But just to get that concept of this, you're stuck with this, it was very hard to register. So I started on some medication. Now I just want to tell you that, you know, everybody is different. I spoke to so many different patients. One thing that helps one person doesn't help another person. You know, the same thing with diets. And what drives me crazy is that someone goes on the daisy diet, and they only eat daisy flowers, you know, and then they get better, and then they're convinced, and they go around telling everyone, including my mother, the daisy diet cures IBD. And then my mother's calling me every day, did you eat your daisies today? And I say, no, Ma, I did not eat my daisies. She's like, listen, you know what? If you don't want to get better, whatever, you know, that's up to you. But I'm just telling you, the daisy diet just gets you better. And then another friend tells her that you got to eat only mushed yogurt that's left out of the fridge for 30 days so that it gets the right bacteria in there. And then for the next couple months, she's telling her, no, I'm telling you, my friend, she gave it to her daughter, and it got better. And it's a huge thing. I mean, listen, my mother, you know, it's hard when you have a kid that is suffering and you want them to get better. But just when you find out that a certain diet helped a friend or it helped yourself, don't become the spokesperson for that diet, because everyone is different. Every single person is different. And I think that I've definitely gotten flare-ups caused by my mother bugging me every day, trying to lay guilt why I'm not on the daisy diet. So that said, I went on the usual plan. I went on the ASAs and the first colazole and the Asacol and the, you know, every kind of form of ASA possible. Nothing really happened. And then, I tried it in every single place they could put it, and still didn't really help the situation. But I decided I am not letting this disease get to me. I'm going to do whatever I want to do. So I still traveled the world. I did a camp for Jewish orphans in Russia, and before I left, I told the doctor, I'm like, if it doesn't get better or it gets worse, is there something you could give me? So he's like, okay. He wrote out steroids and some other things. What? Depends? This is before Depends became cool. You know what I'm saying? Before they made like underwear-looking print on the outside, you know, and ones that don't sound like when you're walking. So so I took with me to Russia some drugs which I didn't really know what it was, and it was kind of like in case emergency break glass here, and it was really getting bad. So I'm like, why? I'm sitting around with this stuff. Why don't I just take it? And so I went to my friend, and I'm like, what do you think? I mean, I Googled it, and it had some weird side effects. And my friend said, hey, listen, look at a Tylenol box, okay? That also gives you a whole bunch of, possible side effects. They just write that for the lawyers. It's just the lawyer stuff. I'm like, okay, you're right. I think you got a point. So I took the drugs, and a few weeks later, I went to the doctor, Dr. Rosen, I told him, my hip's bothering me. I don't know why. It's just, I'm limping around. And he sent me to good old Zellman for x-ray and stuff like that. And then he calls me up and using some, extreme language, he was upset. And he said that you have osteonecrosis, aka vascular necrosis, which basically cuts off the blood supply to the joint, not that kind of joint, which we'll talk about later, that might help the IBD, but it cuts off the blood supply and it basically starts dying. I didn't even know you had blood going on in the bones. Who knew? So apparently that's what keeps it alive, and if you don't have blood going in there, boom, it's dead. You're starving, mamish. So that's what happened, and we start doing research on what to do. The first thing is to check. They checked the other hip and stuff like that, and I had it in multiple joints. And I was on these steroids for about 4 weeks. So I was Googling around like crazy. This is before Yahoo was invented. And I found a doctor in North Carolina, Duke University Medical Center, who was doing this kind of experimental procedure called a free vascularized fibula graft, which they take out the fibula and they make a hole in your femur, which is the big bone, and they stick that inside, and then they do a microsurgery to reconnect the blood supply from the fibula into the femur. You following? Okay. So, and that it does tchias hamesim, brings back the life into the joint, which we'll talk about later. And it seemed interesting because the problem is, if you get a hip replacement when you're young, then they write if you're active, it could last for 5 years, and then you have to get another one, and you only could get a limit of two per customer. So I decided that this looks interesting. I'm going to bring it to Dr. Rosen. So before I told him anything, he's like, okay, I did some research, and in North Carolina, they're doing this free vascularized fibula graft. When he told me the same thing that I thought was the thing that stuck out, I'm like, all right, we're going to North Carolina. So I got surgery on both hips. Thank God it revascularized. And but throughout the years, I really have not gotten into remission. I've been having flare-ups. I mean, just one big flare-up. Sometimes the flare-ups get a little better or worse, depending on what diet my mother comes up with. And so it came to the point where they were suggesting I take biologics. And biologics, I looked at the side effects, and now I really took the side effects seriously. And I saw, 3 times more likely with cancer and this and that and whatever. So I'm like, no, I'm not going there. And they're like, listen, your colon's completely flared up. We're going to have to do surgery or something. So I went to the third option, obviously, which is moving to California. That seemed like the logical third option. I don't know, I literally just followed my gut. I told my wife, I'm like, we're moving to California. She's like, okay. And 2 weeks later, we moved. Just like that. And for 2 years, literally, like 2 weeks after we moved, I went into complete remission. And for 2 years, I was in remission. And when you're in remission, I was feeling like, how in the world was I able to live like I did back then? Suddenly I had all this energy, and I felt like a mensch. I wasn't running to the bathroom every 3 seconds. It was just amazing. It was like, how was I able to live like that? But anyway, after 2 years, that went away. So of course I went for all the biologics, the needle things and stuff like that. And now I am on Entyvio and tacrolimus. Ever heard of that? Okay. Yeah. And thank God I just went to Dr. Rosen today, and I am happy to say that I'm pretty much in remission as of this week. Yeah. And I haven't weighed this much, I know. I haven't weighed this much since I was in smicha. I know. I gotta go on a diet. Yeah, so it must be the daisies. Yeah. So, it's nice to give an update of something that's happy. Now, I just want to reiterate again, not to get anyone scared of steroids or anything like that, because I know that it's a necessity for a lot of people, and I'm 1 in a million, like my wife says. And don't get scared, because you got to weigh the different risks. Anyway, that's my story. And of course, along the way, I've had a lot of different, things that happen as side effects. For example, not too long ago, I'm running to the bathroom in the morning, and I realize there's no reading material. So, I don't want to read the ingredients on the shampoo or something like that. So I quickly turn around to get my phone from the nightstand. I grab it, turn around again, and I'm going really quick because it's like 3, 2, 1, And on the way, I stubbed my pinky toe in the bed, and it literally went, from straight to this way. Like it was facing that way when it's supposed to go that way. And, but that, you know what? That didn't stop me. I just continued running. I'm like, I'll figure out where to put that back once I'm sitting on my throne, This is what I call game of Crohn's. And so I'm sitting there, and I thought it's, I remember as a kid they said if your nose breaks, you got to put it back into position right away or else it stays like that. And if you're Jewish, it's a lot that's staying like that, So it's very noticeable. So I decided it's probably the same thing with my pinky toe, and I better put it back quickly. So I'm like, 1, 2, 3, and then it went back. I cracked my pinky toe. So, you know, IBD causes cracked pinky toes. In a survey in the Pellin household, we realized after much study that patients with IBD, 100% of patients with IBD in the household get pinky issues. You know, other issues happen, like this past Hanukkah. I was at this, you know, Hanukkah Wonderland, and I had to run to the bathroom. I get to the men's room, and this is out of order. Look at the women's room. It's very much in order. Very much in order. And, you know, I remember hearing on the news all this battle of like, hey, you know, men and women shouldn't have different bathrooms, you know. And suddenly I agree with them, you know. I'm like, yeah, you're right. Men and women, that's discrimination right there. So I like walk into the women's room, and I'm like, hello, from me? No one was there. Perfect. I run in, and I was sitting down on the throne. Anyway, like 10 minutes later, after I finished the whole drudge report, suddenly, I guess they were having a show upstairs, and they finished the show. Just a wave of yentas coming, just like they're all over the place. And they come into the bathroom, and I realized that a lot of women go to the bathroom not even to do anything, just to talk. I'm telling you, they're just yenting, talking about shidduchim. You know, I think he's looking for someone that is short, because he's short himself, you know, so he doesn't want the same height. And like, well, she's a little taller than him. It's perfect, don't worry. He can't be choosy. He has that thing over there. They're yenting away, so I quickly like put my shoes against the inside, you know, no one's in here. There's 3 stalls, and then more and more people come in, and then they decided that they're going to wait online. And I'm like, you know, let me just wait till this all goes away. And then the extreme yentas start knocking on the door. Are you okay in there, Zisalach, or whatever? And I'm like, no, I didn't say anything. And they're like, hello? Is everything okay? I'm thinking, should I like whisper? Maybe I should say, yeah, everything's fine. I really didn't know what to do. I waited there for like 15 minutes, and it's not going anywhere. You know, it's like this process that when women go to the bathroom, it's a process, you know. So I like, you know, there's nothing I could do at this point. So I flush the toilet, I walk out of the stall, all the yentas are there, they're all looking at me. I go straight to the sink, and I wash my hands with soap, and then I turn around, I'm like, what are you guys doing in the men's room? And they start like looking around. You know, you gotta learn, you know, with IBD you learn how to handle situations. That's one of the side effects of IBD. You learn to handle situations. You also learn like which tissues are better. Like for example, I just went to Empire Kosher, and there's one thing that a veteran IBD never uses again. It's these. Remember these? These plastic ones? I realized the fancier the box, the worse the tissue. You know what I'm saying? And You know, like, it's much better to go with these on Shabbos, you know? These are good. They're like triple, they're ultra soft and strong, 3 plies, okay? And then the worst thing is when you're in there and they have these. This is the enemy right there. That's the enemy. Because sometimes I need to use the whole entire thing. You know? I get involved. It's not easy. And of course, you know, you go to Fabrengens if you're in the, you know, the demographic. And, you know, the guy's always like, no, Mendy, make a l'chaim. I'm like, no, I'm okay. I'm okay, because alcohol. And they bug you and bug you. No, make a l'chaim. I'm like, yeah, I had a l'chaim. And until you have to just like throw potato salad at him to prove that you've made enough l'chaims. I realize that that's effective. So anyway, that's basically my story. I could go on and on about, you know, different things that, you know, someone with IBD has to go through. But the main thing I want to tell you is that you guys, you're not alone. We're not alone. When I was, you know, for the first couple of years I was diagnosed, I literally thought I was the only one in CrownHeights that had it, because no one speaks about it. I thought I was the only one. Until one day I walk into my friend's house, and I think he was here. Yeah. I walk into my friend's house, and I see a big bottle of Colazol on the counter. And I was like, what? Other people have that too? And so I went right up to the bottle of Colazol, because I forgot to take the dose in the afternoon. And I scoop up like 4 of them, and I just down it. And the father's looking at me. And I don't think that you should. I'm like, no, it's good. Vitamin C is very good for you. You know, it's really good. But that's not vitamin C. That's not vitamin C. It was so reassuring. I'm telling you, that was a moment where it was like, I'm not alone. And that's the main reason why I wanted to make this event is really to break the stigma and know that everyone's going through something, okay? We might have IBD, other people might have worse stuff, but everyone's going through something. And every person that I met that's going through this journey is really an incredible person. You've been chosen because God knows that you can handle it, okay? So you should wear it as a badge of pride. I know in some circles, the spouse, and this is truth, the spouse doesn't even know that their spouse has IBD. You saying that's impossible, but it's true. It is true. Like the wife will hide it in the sheitel box or something, and then she'll go, when she goes to the doctor, she says, I'm going shopping. It's really, 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 when I heard this, that story, I was just like, I told Yoeli, like, that's it. We gotta do something about that. I mean, that is horrible, because I think that alone could create a major flare-up, and it is so important, because who cares? The parents say, don't say anything to anybody that you have IBD, or else you're not getting married, or you're going to get married to someone that has no limbs, or from Russia. And the fact of the matter is, I'm kidding about the Russians. I'm just joking about that. I'm joking. But it is, and then once they get married, it's like now we can't like suddenly, surprise! I gotta go to the bathroom. You know what I'm saying? We can't do that. So there are people literally living, like the husband's like, why do you keep on going to the bathroom? Are you calling someone? You keep on leaving, shopping. Are you cheating on me? No, I have IBD. Oh, that's even worse. it's really, 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 really sad to see that, and I think that it's so important. And that's why tonight I'd like to urge everyone to write down their name when they go out. If you'd like to be a part of local support groups, and you could message me on Facebook if you'd like to be a part of a secret support group that we created. And without further ado, with that said, I'd like to call up our next celebrity doctor. And we're going to be talking about surgical treatment of IBD, when it is needed, and what are the different options? Because that's always the scary thing. You know, when do I have to leap there? When is it bad enough? And so to address that, we have Dr. Feza Remzi. He's a professor of surgery and the director of Inflammatory Bowel Disease Center at NYU Langone Medical Center.
Thank you so much. I'm very much privileged to be here, especially considering the fact that myself and my family, we just moved approximately 2.5 months ago from Cleveland after 26 years. It has been a wonderful experience so far, and we're humbled to be here. So, in the next 20 minutes, the thing that I would like to talk to you about, where I have the unfortunate but fortunate privilege of serving you at one point, and that's an unfortunate reality. All of you would like to avoid me. But the plea that I have is that when you talk about the surgery, the time of the surgery is something really worthwhile. And if you ask me whether do I have a clear answer as the time of the surgery, we don't have a consensus. My plea to you and the request as patients and family, I think everybody needs to have a target. Target about what is the expectation of life. I think it's very critical for one not to decondition themselves, which means lesser way of living as a norm. And that's a significant concern, as my friend was talking about this, the living as a lesser way of a norm. I think that's very important to avoid that, and how we're going to accomplish that needs to be looked at it. Why timely surgery is important? Because if we don't have a timely resection, if we have a timely resection, it may achieve a rapid disease remission, reduce the time to return to daily activities. And surgery after failure to respond to medical therapy might be required to treat the complications, and the overall results might related to that can be much higher. So don't let the IBD get complicated. It's okay to get the IBD disease to get complicated, but don't let the complications get more complicated itself. And then if you do have the surgery late, then you get more complications. So what's the solution? I think having a timely discussion about what's the surgical options there is very important, and having a synergistic relationship with our gastroenterology colleagues and everyone involved with the care of the patient, and clearly defining the goals. What exactly what we're trying to accomplish in our medical management, and when it's the time to come to surgery. I think that's very important, not to have an unknown uncertainty, which I just personally heard it right now. Years and years after of uncertainty, that's unfair to the fellow human being and to his or her loved ones. To have goal and have a consensus and to accept, as much as there may be some differences and morbidity related to the surgery, let's not accept a lesser way of living. So let's talk about the ulcerative colitis. We're going to talk about ulcerative colitis, and then we're going to talk about the Crohn's disease. When you talk about the ulcerative colitis, these are some of the options out there. What exactly does this mean? This means the fact that total abdominal colectomy and ileorectal anastomosis, which means removing the colon and hooking up the small bowel to the rectum. This was an old procedure before the gold standard procedure, J-pouch, came out for ulcerative colitis, where someone can avoid a permanent bag. So this was the procedure of choice then. Today, we may use it in certain circumstances where the patient is really obese, they have an advanced cancer, or the diagnosis is not clear as ulcerative colitis or Crohn's disease, that may be a good option. Removing everything, which is called a total proctocolectomy, and giving somebody an endoleostomy. When do we do that today? Patients that cannot handle a gold standard procedure, such as a J-pouch, obesity, and some other factors that the patient did not work out for the J-pouch procedure, when one may end up with a permanent ileostomy. This is a procedure that's called a Koch pouch, named after Nielsen Koch, the Swedish doctor, who did this original surgery in patients with a parasite of the bladder for urinary bladder, and we took it now applied to colorectal surgery. In this one person do not have to wear a bag outside, but they need to intubate 3 or 4 times a day to empty the stool, so they avoid a permanent bag. This is a good option, again, in patients that are not a candidate for J-pouch procedure. This is called the ileal pouch anal anastomosis or J-pouch procedure. Ileal pouch anal anastomosis or a J-pouch procedure, where, no, that's called a Koch pouch, sir. Continent ileostomy, that's what's called, where you do not need to have a permanent bag. The problem with this procedure, it needs a motivated surgeon, and it needs a motivated patient, which is that one may need at least close to 3 times of a revision over a 10-year period. So it needs to be done with humility and modesty and experience, hence it's a complex procedure. Sometimes we may have to just remove the colon and give somebody an endoleostomy for a while. That's called a subtotal colectomy, which means removing the colon partially. This is usually a initial staging procedure before one gets a J-pouch procedure, when patient has been so sick so long with a lot of medications that it's not safe to do the J-pouch in this setting. But today's day and age, I think the gold standard procedure for patients with ulcerative colitis is removing the colon and the rectum and creating an internal reservoir that's called a J-pouch procedure. And how will we accomplish that thing? It's a complex and technically demanding procedure. We have to remove someone's large intestine, removing the rectum, and then going all the way down to the level of the anus to create an anastomosis. And this is the way how you assess it. You put your finger to the anal canal, and your proximal interphalangeal point is the point where you will be coming across a technology, a staple gun. In a way, it really changed the way how we practice in surgery. You remove that part, and subsequent to that, you create your J-pouch, which is creating a J-pouch design reservoir and hooking the things down to the level of the anal canal, anus. And again, could you imagine in the past we weren't able to do these things, and now we have these staplers that we can hook the patients back up so they can avoid a permanent bag for the rest of their life. I think that's very critical. This device, it's a stapler gun. You put one anvil to the pouch and the other one, the other side to the anus, and you have the shaft to come together, you tighten it up, and then you fire. That firing creates a circular stapler and cutter, and then you can hook the things back up and avoid a permanent bag. However, our patient is going to need a temporary bag between 3 to 9 months period of time for the safety reasons, and between 3 to 9 months period of time, we close this ileostomy with a simple procedure and avoid a permanent bag. Success rates of this procedure is around 95 to 96%. Now, there are technical issues. The reason I'm talking about this is not a straightforward procedure. There are issues that things may not work out. The things may not reach out. So with humility and modesty, you need to be accustomed to these problems to handle this problem. Otherwise, the patient may end up with a permanent bag. These are the techniques, too anatomical, that may be worthwhile, too anatomical, that one needs to have an experience to handle this complex problem. So let's talk about the simulation. This is the way how we do the procedure. We check the area of the transection, come across that area, then when we use the staple gun, remove the rectum, and use this circular stapler, what we call it, put it down to the anus, then come across, and it's very critical, especially in females, if we're not careful, God forbid, you may pick up the vagina and create a disastrous complication. So one, when you deal with these procedures, you need to be humble, but also you need to be confident to help the fellow human being to avoid a disastrous complication. And this is the techniques. It's very critical. This is a very, very important life-threatening vessel. A little injury to this vessel can significantly impact the outcome of the procedure with some of the reaching techniques that I was referring to. This is also the case how we do the anastomosis. I like to bring the meso where the blood supply comes posterior to the pouch, so it's a less issue at ease that I felt in my hands. Some people may like to do it a different way, but more important that when you do that thing is you need to do the right size of the pouch with a minimum tension as shown here. Again, innovation has changed the way how we practice. You fire these things, come across the tip of the J pouch with another linear stapler. You oversaw this area. You check for a leak. If there is no leak, then you do the anastomosis. And by that way, you give the patient a chance to avoid a permanent ileostomy for the rest of his or her life. Now, this is some of the things that I always try to push hard to my residents and fellows that I'm privileged to train, because that's important for the next generation. A lot of people ask questions, who's going to do the procedure and everything. This is no joke. This is the top part of the procedure that I personally do A to Z, but it is also my obligation for them to be around to know the next generation so that they can serve for the future generation and our children. But the things can go wrong. So you need to know some of the tips and tricks to avoid this complication. If those complications can happen, you can handle it. Now let's talk about briefly some of the controversial topics when it comes to ulcerative colitis surgery. Is it okay to do the elderly population? The answer is yes. I don't think age does not matter. The oldest fellow human being that I had privilege to serve was around 80 years old. He was a very well-built gentleman, and he was very healthy. Is it okay to do it when somebody is sick, what we call toxic colitis? The answer is no. That's the reason today we stage these procedures. Patients that who are really sick, low albumin, nutritionally not well, those are the patients who like to stage these procedures first. Is it okay to do patient with cancer? The answer is yes, but we cannot compromise for the intent of the cancer surgery that we're doing. Because what matters is the living life. And we cannot make a compromise just to avoid a permanent bag. There are different ways of doing the things. Some people talk about a hands-on technique, which I do not recommend. I like to recommend a stapling technique because it gives a better function and less complications, at least the experience that we had throughout the years. The risk of cancer in that area that's left behind with the stapling technique is very minimal, but the same risk also exists in patients where we strip that area to the last bit of the anal canal. When somebody has a pouch, I think it's important to follow up yearly in most of these settings. If the patient did not have any cancer in the specimen, then we may go up to every 2-3 years. You're going to hear about the J pouch, S pouch, and everything like that. It doesn't matter. This first pouch that was done was an S pouch, but today we use a J pouch because of the ease of construction, and the results are very good. Now, can we avoid a bag? A lot of patients ask me this question. And this is sometimes used in our country and other countries for marketing reasons, and I caution you for that. I'd rather have a fellow human being to have a ileostomy for 3 months to 9 months, rather than dealing the disastrous complication of not having an ileostomy during that time and suffering for the rest of his or her life, potentially ending up with a permanent ileostomy. So we need to challenge our surgeons to ask those specific questions. Why do I like to avoid ileostomy, but what are some of the risks related to that? It's very important. Is it okay to do in patients with internal colitis? The answer is yes, but we have some caution to be aware about that. Some of these things may convert to Crohn's disease. Is it okay to do it in patients with Crohn's disease? We're getting more and more liberal with the fantastic gastroenterologists we have, complement the medical therapy in the presence of Crohn's disease. However, not in the presence of severe small bowel disease or severe perianal disease. I think it's a topic that we're going to expand more for the future. I have been liberal about this to my patients after vigorous consenting, as long as they are the ones who like to avoid a permanent ileostomy, as long as they understand that and we have an understanding, we have always been in their service to help them. It needs a collaborative effort as the panel that you're seeing, because this is not alone a surgeon issue. This is about the patient, their outcome, and a collaborative effort together. Patient has a J-pouch. What type of delivery that they should be having? When you look at the literature, vaginal delivery is safe. The studies that we have done, at least before I came here, that we didn't agree with that. Especially in our country, most of the gynecologists, they do cut right in the middle, rather than Europe or Canada cutting medial lateral. And one little injury to that pouch may equal to endoleostomy, so I do recommend for our patients doing a C-section in these settings rather than a vaginal delivery. And there are results to support that. Now, can we do it with a minimally invasive, with a small procedure? The answer is yes. This is very, very technically feasible. It's actually excellent, but be careful it is done in the experienced hand to avoid disastrous complications, because at the end what matters is functioning the right way for the rest of your life rather than having a small size of incision. It can be done. It has excellent results. It needs to be done in experienced hands who does these a lot. This is some of the procedures that I had the privilege to take care of with a single port, and it can be done. We just need to be careful about that things go well and not to compromise what needs to be done. When you look at the ulcerative colitis, the results are very good after surgery. Approximately 97% of the patients that they wish they had this, they would undergo this procedure again, and they would recommend to the patients in their situation. In the last 5 minutes, I'm going to talk about the Crohn's disease. And this is, Dr. Crohn's who initially defined this disease. What we're seeing in these numbers, there's the unfortunate but fortunate reality, the fact that at one point, myself or my colleagues as a surgeon will have the privilege to serve our patients. Despite the great drugs, this still has not come to a point. I love to come to a date the fact that I'm not practicing surgery for inflammatory bowel disease. We're not there yet. Until we come there, we will have to have targets and understanding without compromising your life, our patient's life, what is the right thing to do. It's an individualized decision, but I plead the conditioning is something that I see so much in our IBD patients, accept a lesser way of life for the sake of the family, suck it up, don't say anything. That's something I think with a collaborative effort we can avoid and work on this together. Now, operative indications in the acute period can vary, but there's also chronic indications of the surgery. So, however, the number one indication the patients do require surgery with Crohn's disease is the fact that failure of medical therapy. Now, when someone operates on the Crohn's disease, one needs to understand the fact that Crohn's is incurable. It's a negative word. We need to understand the reason why we're there. We cannot cure Crohn's surgically. Surgery is most of the time intestinal complications. The surgery is impacted many stuff, many factors, and we should be putting the asymptomatic disease aside and not to worry about it. Picking up the right battle for the sake of the patient at the time of the surgery. So if someone has a very severe disease of the ileum and the cecum, let's remove that area. But there's a skip lesion that is not obstructing up in the jejunum, just leave that alone. That's not today's problem. There are several options with the Crohn's disease. As you know, Crohn's may impact any part of the body. The most common is the ileocolic area. It may impact the small bowel, and it may impact the colon and rectum, and also it may impact the anus. So these are the type of the procedures. Bypass procedure. This was the original surgery that was done for ileocolic through Crohn's disease. Actually, one of our presidents, Dwight Eisenhower, had this procedure done. We kind of eliminate this procedure because it creates an infected mucocele and it increased cancer risk on this bypassed area. So it has been really abandoned. The resection, which is removing the part, it's still the procedure of choice today. And most commonly it's used for the ileocolic area, ileum here, cecal here, or ileocecal area. In the past, we didn't know how much we were going to take, so we used to do intraoperative frozens and go crazy about it. We did a study with my mentor many years ago, and we found the fact that just feeling it the right way with one's finger, it needs to be an experienced finger with humility and modesty, index finger and thumb, and you feel the fact that you can touch across the mesentery. That's the time and that's the place that you can use as a margin of resection. And resection is still the #1 procedure and way of doing the things, just eliminating that disease when the medical therapy and everything don't work out. Patients are legitimately worried about having a bad ileostomy. I tell my patients, as the way our friend said before, if somebody is going to like you less or more because someone has an ileostomy, that may not be the right person to get with. And the fact is, in this situation, this temporary ileostomy is temporary, one needs to understand, and it saves life. And I like to use these in these settings. Patient that where the surgery still has an active infection at the surgical area, too much blood loss, prolonged surgery, and hypoalbuminemia. These are the patients I'm very liberal giving an ileostomy for 3 months, which patient may be upset to me, rather than to be upset and suffering for now a year and a half with pure agony. That's the plea that I like to make. If somebody gets an ileostomy, they need to understand, as what I said. That's what I tell to my patients. I treat my patients like they're my family. It's about availability, affability, ability, and accountability when it comes to inflammatory bowel disease, and the passion to take care of the fellow human being. Laparoscopy can be done in these settings. We just need to understand the advantages. Some of the disadvantages doesn't matter. The advantages outweighs the disadvantages, and it's something that I strongly recommend as long as it can be done safely. The other type of procedure is called a strictureplasty. Strictureplasty is when there is too much strictures that you don't want to take the whole bowel out. You do this type of opening mechanism of the obstruction. This is called a certain type of strictureplasty, the Heineken-Michelix. You make the incision longitudinally, close it transferally, you overcome the obstruction. Medium length strictures can be done this way. This is side-to-side anastomosis. Or the other one, when the things are really long, this is a different type of strictureplasty. So there are different ways of doing the things. The results as good as the resection. So if one has one resection and they may be impending for a further short bowel syndrome, we're very liberal about the strictureplasty with excellent results. Colonic disease, which means the bowel disease is impacted, large bowel is impacted, Crohn's disease. There has been a big argument about removing the whole colon when the rectum is normal or doing a segmental resection. These are the different options out there available. The results show the fact that segmental and total colectomy has equal results, and I do prefer a segmental resection in these patients to avoid ileostomy. Let's talk briefly about the rectal disease. The options in these settings are removing the rectum and giving a permanent ileostomy. It's a detrimental effect. One has to live a permanent ileostomy, which may be the unfortunate reality, but the reality also is it is the quickest way of curing the Crohn's disease in these patients. Fistula disease. This is the part that I beg Dr. Hudesman and my, the gastroenterology colleagues that we're not sufficient as a surgeon to handle this, and we need to have the biologics to work together. The frequency can vary. There are different options to treat these things. There are so many different options for this thing. Cutting ceton, non-cutting ceton, which means providing a drainage patients. So we put this cetons in the patient's, the fistula tract. It provides a drainage. The aim of the ceton is to avoid a bag. And I think it's still a very great, useful procedure, and the patients are okay with it. It causes very minimal amount of discomfort. This is what the patients say. Laying the fistula open can be done, but there are some concerning findings. You can create incontinence on these patients. A flap procedure can be another option with some success rates. And there are different types of flaps that exist in these settings, and this is a rectal sleeve exam and a complex flap. Success rates variable, and that's the reason we need the biologics in these settings. We use the fibrin silent with a very dismal results. The results has not been that good, and sometimes we give a temporary bag to the patients to see how they're going to do. I think this is bridge potential of permanent ileostomy because the success rate to be able to close one's ileostomy is around 20%. One thing that is up and coming, which I think have a great future, is a stem cell on these fistula treatments. Right now, it is available in a different way in our country, but there are newer products coming, one from Spain and then Korea, and we'll be starting those trials in the future. At the end of the day, I think it's very important to have a timely discussion of both surgical and medical options in our patients, and clearly defining the goals, medical biologics therapy, and clearly defining the criteria for referral to surgery as a joint synergistic approach and better understanding the contributing factors. I'm really honored being here. It has been a privilege. Thank you so much for listening.
Thank you very much. Really appreciate it. Those pictures there are all the pictures that in Yeshivah they tore out of our science books. Just for the people that spoke so far, I have imported 3-ply toilet paper. Thank you very much. You can take that home with you. Thank you. Thank you. Of course. There you go. All right. You're going to have to earn yours. All right. Now let me just tell you something. We of course saved the best for last, and then after that we're going to take some questions, and the questions right now we're going to have people passing out cards that you could write down questions, and I will ask those questions. Very important to if you want to stay connected on your way out. We have a list. Please put your email address, and you can check off if you want to be part of a live support group or a secret one on the internet. And we'll be in touch with you via email. Very important. Our next guest here is someone that is a pediatric IBD. Developing and growth is what we're talking about here. And she is the assistant professor at Professor Pediatric Gastroenterology, Mount Sinai Hospital, and it's really amazing that she came here tonight. I know it wasn't easy, and it's so difficult when young people have this disease. I know it's really tough, but you know, Dr. Nancy Pittman is really a real-life hero. Helping the kids and the parents is a big thing, the parents. And she's going to talk about it right now. Please give a round of applause.
Hi everyone, good evening. It is a pleasure and complete honor to be here tonight, and thank you all for staying so late. I would like to speak to you about pediatric IBD, and of course, all the lectures that you've heard tonight from my adult colleagues, all of this applies to pediatrics. So what I chose to do tonight, with Yoli's suggestion, was to pick a topic that really doesn't apply as much to the adults. So a lot of what you heard about the medications we use across the board, the way patients present, etc., are very similar. But we're going to talk tonight about something that's a little bit different and unique to pediatrics that is extremely important. So pediatric growth and development can be affected by IBD, and it is a major topic that we address at every visit when children come for consultation and follow-up. So the incidence of IBD is growing in the population in general, and there are approximately 80,000 children in the United States with IBD. Because of that, it's really essential that we have a very clear understanding of IBD in pediatric patients. We have to really recognize the clinical presentations, how to make the diagnoses quickly, how to monitor them effectively, how to give them treatments that are going to be effective and safe, because many of them could have another 90 years to live, so we need to make sure these medicines work, last, and will not have any long-term complications. And we also have to look at the prognosis. So if you're going to make somebody better for 2 years when they're 10 years old, that's not going to get us very far when they're sick again at 12. So we need to try to make sure that when we treat them effectively, and we have to look at their whole life ahead of them to make sure that we're doing things properly at the beginning so that we could actually change the course of this disease. So pediatric IBD, is there really any difference? Well, the diseases are really the same. The presentations are the same, but the complications can be very different if the disease is not addressed effectively. So the similar symptoms are belly aches, diarrhea, rectal bleeding, poor appetite with weight loss, fatigue, fever. Sometimes there are extraintestinal manifestations that affect the eyes, mouth sores, joint pains that come even without the use of steroids, as was mentioned before, but just joint pains due to the disease. You can have rashes such as denodosum or pyoderma gangrenosum, and many of these extraintestinal manifestations can actually be the first presenting sign before there's ever any GI symptoms. So children could be going to rheumatologists for joint pains for many years before they're diagnosed with IBD. So instead of talking about the symptoms that are similar, let's talk about unique symptoms for children. And the one that I like to talk about most is a decreased growth velocity in children. Some people term it short stature, but you don't have to be short. You could be growing at a very high pace, but if all of a sudden your rate of linear growth decreases, then that is a decreased growth velocity. That is as important as how tall you are. So it's not essential how tall you are, but that you're following your predicted growth velocity. And I also like to focus on sexual maturation to make sure that children go through puberty appropriately. Otherwise, that can affect their fertility long term. Growth delay is much more common in Crohn's disease than in ulcerative colitis. So most of what I will be talking about applies more to Crohn's disease, but about 5% of children with ulcerative colitis can also have growth issues. So in pediatric IBD, there are some children that will have very mild disease, where they'll respond to the aminosalicylates that you mentioned, the colazole, acicols, the zolfidine, etc. But many children will have moderate to severe activity. And those children have to be diagnosed quickly and treated effectively so that we can get them better quickly before they have any complications. So the children who have moderate to severe disease often present with growth failure, weight loss, and they'll have persistently active GI symptoms despite the basic medications. So it is very important at the time of diagnosis to say, is this a patient with mild disease? Can we use the simple aminosalicylate medications? Or is this a child with moderate to severe disease, and do we need to jump right in with aggressive therapy early on? The faster we can get the disease under control and achieve mucosal healing, or what one of my colleagues mentioned was treat to target, but to actually go back with the colonoscopy and see that all the colitis is gone, all the Crohn's disease is gone, that will lead to a better prognosis ultimately in children for the rest of their life. So we would like to aim to diagnose kids quickly, properly, effectively, and aim to change the course of the disease in that particular patient. So one of the things we look at is something called a growth curve. And a growth curve is an essential part of every pediatric visit, having nothing to do with pediatric GI. So whenever you go with your child to the pediatrician, they get a height and they get a weight and they get put on the growth curve, and this is very important to make sure children are gaining and growing at the right velocity. It doesn't really matter where on the curve a child sits, but you want them to follow their own curve. And any deviation off the curve is something that would warrant evaluation. And you want to try to aim for the child's growth to approach what we call the mid-parental height, which is a calculated average of the mother and father's height, adjusted slightly for gender. So we want to look at how tall are the parents so we know what we should expect from the child's growth. So this is a growth curve, and on the x-axis is the age, and on the y-axis is the weight, and a little higher up is the stature or the height. And so where you are on the curve, whether you're at the low line, whether you're at the top line, whether you're below the curve, that part doesn't matter. But the shape of the curve, the slope of the line, and the rate of linear growth and weight gain is essential. So when children come in, they get weighed in very thin clothing, or if they're not in thin clothing, we have them put on a gown, because it's very important to have an accurate weight. We then take their heights using something called the stadiometer. This is something that is mounted on the wall so we can very accurately get a height. And the children are very into their heights to see if they're actually improving each time they come. So we get this, this measurement each time, and we plot them on the curve. Now, this is a growth curve of a patient with IBD, and as you can see, this curve is all along the lowest line, or the first percentile, but the curve is perfectly fine. It's in the right shape, and if you see this little triangle over here, this is the mid-parental height. So not only is the line straight and following the proper slope, but it's exactly going to hit where the parents are. So this is a completely normal, acceptable growth curve. This curve, however, shows a flat line across. Ignore that X, that was a mistake. But there's no growth here. And not until the child was diagnosed and treated for Crohn's disease did the growth pick up. So what do we focus on to achieve this growth? Well, we really need to get proper nutrition. And even regardless of IBD, if you don't have adequate nutrition, you don't grow. So we know that from other disease states where people are calorically deprived, and that affects their ultimate linear growth. In active IBD, however, people often have inadequate calories, and that's usually due to a loss of appetite, which we call anorexia. They can have early satiety, where they want to eat, but they get full fast. They may get belly aches after their meals. They may get diarrhea after their meals. And what children learn to do is not eat. So if they have lunch at school and they have math after lunch, they're not going to eat lunch if they're going to feel sick in math. So they learn to adjust so that they don't have to feel sick. They're going to a special party, or they have to get on a long bus ride or a long subway ride, and they learn to adjust. And that leads to caloric deprivation, which leads to weight loss, which leads to poor linear growth. So therefore, the best treatment is to gain control of the disease activity. The appetite will return, and the symptoms will resolve. Until remission can be achieved, however, you want to increase the calories that a child takes by giving them extra protein and extra healthy fats to the diet. You want to try to make the food that they eat dense in calories, because often they're going to have smaller volumes of food ingested. So instead of eating their whole sandwich, maybe they're eating half their sandwich. So you want to try to add things to the food so every mouthful has more calories per bite. So if you have a picky eater, maybe the only thing you could do is add some olive oil to the food that the child already likes. If you have an open-minded child, try to add some things to the diet, like avocado. Oops. Sorry. How do I go backwards? Okay, like avocado or hummus, eggs. I put cheese in in parentheses, because a lot of people feel dairy can be irritating in IBD, but we use a lot of dairy to help increase the caloric content of children's food. So instead of just having scrambled eggs, if there's melted cheese in the eggs, you just win 150 calories. So it's an easy way to not have to ask a child to eat more to deliver more nutrition. If it is difficult while the disease is still not under control to eat a full meal, then we try to ask people to eat many small meals. And if necessary, we use high protein, high calorie drinks. Now the high protein, high calorie drinks are tricky. You don't want to give a drink and then not eat breakfast. So if it's a child who's not eating breakfast anyhow, then the drink is good. But if it's going to interfere with them eating their meals, then it's not good. So we need to have the proper balance of when to use these drinks so that ultimately they don't get too full from the drinks and then not eat their meals. So it should be at the right time so that ultimately at the end of the day the child gets enough nutrition. So in general, avoiding certain foods and these restrictive diets are not great in kids. Because what ultimately happens is they don't have enough calories. And when they don't have enough calories, they don't gain weight and they don't grow. So there are a few exceptions. Lactose intolerant, if somebody's lactose intolerant, okay, buy lactose-free milk, use the lactose chewable enzymes with the children. If somebody has concomitant celiac disease, so there are children who have both IBD and celiac disease, then they need to be gluten-free. If a person is really flaring and has a lot of diarrhea, they may not want fruits or vegetables. That may increase anybody's chance of having diarrhea. If somebody has a narrowing or a stricture, maybe decrease on the amount of raw vegetables or raw fruit. But in general, we don't like to make rules. We like to say, eat enough calories with healthy food. And if there's something specific to that patient that bothers them, okay, forget that one thing. But we try not to remove any one food group unless we have the lactose, the celiac, or a stricture present. Now, is it better to not eat apples if apples hurt you? Well, maybe you could have the apple but just don't have the skin. So we try to make adjustments so that you can still have all the nutrition from the food rather than just throwing it away completely. Now, enteral nutrition is a very hot topic. A lot of patients want, well, not so much the patients, but a lot of parents want to try enteral nutrition on their children instead of medications because of the study that was presented earlier, where they did show that children got better, and they did show that when they repeat the scopes, there was improvement. The problem is, you can't stay on these diets forever. And so if you're going to use it, the child has to be committed to stay on these diets long term. So it has to have an endpoint. So if you're going to use it as a bridge to get the disease under control until something like Remicade takes effect, no problem. But to ask an 8-year-old child to be on this diet for the next 90 years is a hard thing to do. So it has to be very clear what these diets can do. But when you do use these diets, they don't work in everybody. And you have to really make sure that you have adequate daily calories coming in, that you really are still gaining weight, that you're growing, and you have to make sure the disease is under control. So just because the studies show that the enteral therapy worked, doesn't mean it's going to work in the child. So you have to follow up the labs, look at the hemoglobin, the albumin, which is the protein, the 2 markers of inflammation that my colleagues mentioned, the ESR and the CRP, the stool test for calprotectin, which is the inflammatory marker, and really make sure their weights and heights are following along track. So which treatment do we pick? How do we know what to give kids? Well, the first thing is you really want to see how much inflammation is present and where is this inflammation located. So this is a picture of a normal colon. What I like to tell the kids is look at the back of your hand, and a normal colon should look like the back of your hand, pink and clear with the veins streaming through. But when you have inflammation, such as an ulcerative colitis, you no longer see that pink picture. You no longer see the veins streaming through, but rather it's thickened, almost as if somebody put wax paper over your hand, and you no longer can see the vessels clearly. You see bleeding, and these little yellow spots are little ulcerations with mucus that often the children will report seeing in their stool. This is a colonoscopy of Crohn's disease, which looks a bit different, where they have linear ulcerations, but again, very different from the normal picture. So when you see these types of colonoscopies, that is a child with severe disease. This is not a picture of somebody that's going to be able to be treated with mild medication. We also have recently started to do wireless capsule endoscopies, which have allowed us to look at the 20 feet of small intestine in between where our two scopes can go to see if there is a little bit of inflammation, like in this picture, a small little ulcer, or deep ulcers. And again, you need to look at the disease burden, where it is, and then match your treatment, okay? So that's number one. Number two is you want to say, how sick is the patient? Are they losing weight? Are they not growing? Are they anemic? Is their albumin low? Many of my colleagues tonight have mentioned the word albumin, and it's a protein in our blood, and it's a sign of sort of how sick you are. It goes down when you're not eating properly, but it also goes down when you're very inflamed in the GI tract, and you lose this protein in the stool. So it's a marker of sort of how sick you are, how acutely ill you are. So if a person has a lot of disease in their colonoscopy or in their capsule endoscopy, if the child is looking sick, you really need to match your treatment plan so that you have a good match with the disease and the treatment. Once the treatment is instituted, you want to see if the symptoms get better, right? Did the pain and diarrhea go away? Did the appetite improve? Did the child regain their weight? Are they beginning to grow again? Are they actually catching up in growth to what they had lost before? What's happening to their blood work? Are they no longer anemic? Did the inflammatory markers, both in the blood and the stool, return to normal? So after this treatment is instituted, you really can't just leave them. You have to really make sure that everything is much better. And most importantly is you must repeat a scope. And as much as we don't like to put children through follow-up scopes, you need to show that you have achieved mucosal healing. If you have not achieved mucosal healing, you can sometimes tweak the medication, change the dose, change the interval. Sometimes you have to change the medicine completely. But if you don't know that you have healed the mucosa, that unhealed mucosa will lead to scarring and will end up requiring our surgical friends to help us, which we try to avoid, but we're glad you're around when we need you. But with mucosal healing, we can actually change the inflammatory process, the stricturing process that unfortunately occurs in many Crohn's patients. And so if we hit it right, we can take this patient from a growth point like this to growing like this, and we've achieved success. So getting the children to have relief of their symptoms, return of their bowel to normal physiology, and to allow them to gain and grow, go through puberty appropriately, and reach all their milestones, and keep them that way so that they can have a long, healthy life and change the natural course of the disease. Thank you.
Thank you so much. Really appreciate that. And now we are going to take some questions from the audience. The time is late, and these doctors on stage have a more important life than you, so they have to leave here quickly. Thanks so much for staying. Okay, so we're going to start off with the first question. And this is, we'll figure out who it's directed to. So my mother had lymphoma, chas v'shalom, and I am currently taking Remicade. Does the risk get greater with family history? Is it recommended to change treatment based on that history? Yeah.
I think the answer to that is yes, and that with a family history of lymphoma, I am doubly careful about starting the anti-TNF at any point. I think that you could probably find literature, you could probably find studies that show that the incidence of lymphoma in people with IBD is not greater than the normal population when you're talking about anti-TNFs. But I think that although more recent studies tries to show that there's no association, I think earlier studies proved that there is an association, and when there's a family history, I'm doubly careful. You don't find that with all cancers, but lymphoma being the one cancer that is most common with the anti-TNFs, I think we're doubly careful about.
What are the most common medications that are anti-TNF medications?
The anti-TNFs, as Dr. Hudesman referred to before, are one of three medications. One is called Remicade, one is called Humira, and one is called Cimzia. They all negate, or they all block the effect of a compound called tumor necrosis factor alpha. Tumor necrosis factor alpha, in English, is the police state in our body that is responsible for detecting cancer cells and getting rid of them. So that the initial fear was that if you block that compound for a long enough period of time, you would allow cancer cells to go undetected. Turns out that there are probably many more of police states in our body that are able to recognize cancer cells, because the incidence of cancer itself isn't that much higher in people who take these medications for a long period of time. But again, it isn't called tumor necrosis factor alpha for nothing. It's called tumor necrosis factor alpha because that's exactly what it does. It's in all our cells, it's in most of our organs, and we still don't have the final answer about long-term cancer, because sometimes cancer doesn't develop until 15, 20 years. It may take that long for a tumor to develop. We only have these drugs for approximately 15 to 20 years.
So, and how's that different than like Entyvio? How's that different than the Entyvio, if I'm pronouncing that correctly?
Yeah. So I could speak loud.
Yeah.
So as Dr. Lichtiger was explaining earlier, Entyvio works a little bit different than sort of your anti-TNF agents, your Remicade, Humira, Cimzia medications. It's more gut-specific. So if you imagine the cells that cause damage, the inflammatory cells are cars on a highway, and each exit off the highway is a different part of your body, your brain, your heart, your lungs, your intestine. All Entyvio is really doing is blocking that exit off to your intestine, right? So it's not affecting your overall immune system. So with that, and with the clinical trials, we really haven't seen that cancer risk. However, it's only been around for 2.5 years. And when you're talking about cancers that can take 10, 15, 20 years to develop, based on the mechanism of action, based on what we've seen so far, I think we're optimistic on sort of cancer risk with Entyvio, but I also think you have to balance the fact that we only have 2.5 years of real-world experience with the drug. So with all of these, situations, it's all sort of a risk-benefit, right? Whether we could just give you some Asacol and you're gonna feel great forever, that would be great, but in certain situations, maybe an anti-TNF is going to be better than Entyvio or vice versa. So it's sort of balancing that.
Thank you. This question is for Dr. Pittman. A 16-year-old boy on Humira for 6 months, doing fine, has grown a bit, but there's still plenty of growing to do. Is a visit to an endo an option? endocrinologist, letting the medication take its course.
A visit to the endocrinologist is always helpful, except they're going to say, I can't help you unless your disease is under control. So just saying a 16-year-old is doing well in Humira, what does that mean? Does that mean they feel good, or are they really doing well? So the first thing to do is to repeat all their studies, make sure they're really under control, make sure their Humira levels are adequate, make sure they haven't developed antibodies to Humira, and if their disease is under control, then the endocrinologist can take off and help and look for other causes of growth failure. But there's no reason to look for growth hormone deficiency, etc., if the disease is not under control. So it's most important before we look at other causes of poor growth to first say, okay, we have Crohn's, we know it affects the growth, let's make sure it's under control, let's make sure our medicines are working, our levels are good, and everything is good, and then we'll call our colleagues. It's very possible somebody has celiac that's affecting the growth. Maybe they have growth hormone deficiency too, or thyroid disease. But if you have one condition, let's get that under control first, and then see. They can do something called a bone age, which is an x-ray of the wrist that gets compared to a standard wrist of the same age of the person, and can be, we can determine if that child's bones are younger than their chronologic age. So if a 16-year-old boy has bones of a 14-year-old boy, then we know they have time for catch-up growth, which is something that we really love to have, because that gives us time to get the disease under control and then catch up. So sometimes the endocrinologist is helpful in helping us, read the bone ages and determine if the growth velocity can pick up.
You mentioning a lot, check, do another colonoscopy. If someone's doing well, is there a possibility that a colonoscopy, could get rid of good bacteria or something and actually cause a flare-up?
Not to my knowledge. And it's not to keep doing it. You do it once at diagnosis, maybe once a year into treatment to make sure you're good. And then it's not like you have to keep doing them as long as you're growing, thriving, your stool calprotectin is normal, your labs are normal, and everything is good. But you want to make sure that you don't buy into a certain medication and regimen without proving that you've really done the right thing by the child. So you give it some time to work, make sure your levels are good and your interval of how frequently you're giving the medicine is good. And then once that's all established and you have enough nutrition and everything is settled, a year later, let's say, you want to make sure your medication is working.
Thank you. All right, so next question is, what's the percentage of kids getting IBD if one parent has it? Or what's the percentage of both? And what if only a sibling has it? I know my father had ulcerative colitis. And when I was first diagnosed, the doctor said, ulcerative colitis has nothing to do with family history. I think back then that's what the study proved, but now I think otherwise, correct?
Anywhere between 5 to 20% of newly diagnosed patients will report having a family member with IBD. It doesn't always have to be a parent, it could be a grandparent, an uncle, it can skip around the family tree. But then there's also a large percentage, 80, 90% who say they never even heard of IBD. They don't have any family members with it. So it is a condition that's increasing in frequency, and the incidence is increasing. The incidence in children is increasing at a greater rate than percentage-wise. So it's not fully, I don't know that our old data really applies now, but we usually say it's about a 20% will have a family history of IBD somewhere in their family.
Well, I mean, that's heartbreaking, like thinking of a kid that has IBD. I mean, that's tough way to grow up there. Alrighty. Next question is for Dr. Remzi. Is surgery an option for patients with both UC and Crohn's? Thank you for all. 2 exclamation marks.
So, you know, the dilemma here, so UC and Crohn's, there's 2 separate entities. So it's really tough to have both. What happens is, in these circumstances, patients who may have ulcerative colitis later on may convert to a Crohn's disease. So I'm not understanding the clear question, but surgery is a great option for ulcerative colitis. Surgery is a great option for Crohn's disease. Combination of that disease, UC and Crohn's disease, we call it an indeterminate colitis. So if we're not pretty sure if somebody has a UC or Crohn's disease indeterminate colitis, those patients can have the ileal pouch or J-pouch procedure with great results. So the answer is yes. I don't know whether I was able to put that question into some understanding.
Yeah, I think so. I think so. By the way, does, say someone marries a Yemenite, a white person like myself, does that lessen the chances of the kids getting IBD? Any research on, if just 2, anyone aware of any research? If like an Ashkenaz and a Sephardi, because we're very into, the same-sex marriage, and SECTS, and it's I know it's prevalent in us white people, and if Ashkenazim and Sephardim get married, does it lessen it?
There's very interesting data from Israel, fascinating data from Israel, where a couple of years ago, as you very well know, there was a project that was called Operation Moses, where a lot of Ethiopian Jews were brought from Ethiopia to Israel. Inflammatory bowel disease was not seen in Ethiopia. It was a disease that was not described there. Maybe because when you went to your doctor in Ethiopia and you complained of diarrhea, they automatically assumed that you have some kind of infection. There's been some data out of Israel showing that Israelis who marry Ethiopians, meaning native Israelis who marry Ethiopians, their Ethiopian spouses are coming down with inflammatory bowel disease. It has been an argument for those who say that IBD is an environmental disease as opposed to a genetic disease. Same thing in Australia. There's a group in Australia called the Aborigines. The Aborigines are people who live out of modern society. And what they did is they brought, the Australians brought some Aborigines into big cities. And they followed the incidence of inflammatory bowel disease in these patients. Again, Aborigines had no incidence of IBD where they lived. And when they moved into big cities, they developed IBD. Whether that is diet, whether that's other Western habits, whether I'm saying this because it's been thought about whether it's a contagious disease, and therefore a spouse would give it to another spouse. We don't know, but there is incidence now in spouses where we never saw IBD in both the Ethiopians and Aborigines.
Wow, that's pretty crazy. We should get on that. The next question is for Dr. Lawlor, and this is about constipation. Could years of constipation eventually lead to Crohn's, and is constipation a sign that you have inflammation?
I think the easy answer to that is, we never know enough about everything, but the easy answer to that is no. So constipation doesn't eventually increase your risk factors of developing Crohn's disease, or for that matter, ulcerative colitis. Usually patients coming with inflammatory bowel disease are complaining mostly of abdominal pain, diarrhea, bloating, and so on. But every so often you come across patients who have constipation, and we investigate them and we find inflammatory bowel disease, you know, there in the colon or wherever. So so constipation can sometimes be put into that family of symptoms that you see with inflammatory bowel disease. But it's certainly, from what we can see from the data, it doesn't seem to be a risk or a predictor of future inflammatory bowel disease, if that answers the question.
Yes.
Thank you.
All right, the next question is for Dr. Remzi. Someone wants to know, what's that accent? Where's that from?
So I'm a proud Turkish American.
Ah, Turkey.
Turkish.
They were like, there was two people were arguing whether it's Iran or, you know, or maybe a mix of Iran and Russian. Turkey never entered the equation here. Interesting, if that answers the question. The next question is for Dr. Hudesman. How does Humira affect getting pregnant and the actual pregnancy? And what about, you know, any biologics for that matter?
Sure. So I think the first important concept with pregnancy is you want to go into pregnancy healthy, right? So the risk to getting pregnant and complications from pregnancy, inflammation is a far greater risk than any of the medications for the most part, right? Than what we have. So the most important thing before, you know, when patients come to me to discuss pregnancy or of that age, I say before we even think about it, we have to get you feeling well, we have to get you healed inside. And if you're that way going into pregnancy, you're much more likely to do well throughout pregnancy. Whereas if you go into pregnancy with active inflammation, you go into pregnancy with active disease on a colonoscopy, you know, over 2/3, 3/4 of people will get worse or remain sick throughout pregnancy. So that's the first thing. Our biologics are, for the most part, use the term safe during pregnancy. They're category B. What we do have, so that includes your Remicade, Humira. In Tibia, we have not as much data, but we think that's safe as well. And what we do have is this large registry that was started out in San Francisco, but it's multiple institutions across the country, looking at babies that were born to mothers that were exposed or on these agents during pregnancy. And there was really no increased risk of adverse outcomes, congenital abnormalities, developmental delays, you know, not getting an A on their first test, or, you know, all sorts of, you know, different outcomes. However, these medications do cross the placenta later on during pregnancy, so the babies may be exposed to them, the fetus may be exposed to them, although that doesn't affect outcomes. It's something that's very important to have counseling with your GI doctor, with your OB, with your pediatrician, to make sure that the babies get all the right vaccines or maybe not get certain vaccines. So overall, safe during pregnancy, but the most important thing is to go into pregnancy healthy and in remission.
But like things like methotrexate,
Right,
6-MP.
So methotrexate, right. So when I say most, methotrexate definitely not during pregnancy. 6-MP, we could have a debate back and forth, but I think most people, most IBD specialists, if you're on 6-MP and you're doing well, we continue it throughout pregnancy, and we think it's safe during pregnancy. There's some mixed data from some older studies using 6-MP in non-IBD patients, but in my practice, if you're on it, you're doing well, you're in remission, we don't start changing things around. And I think most IBD specialists will let you know that. But methotrexate, a couple others, definitely not. But for the most part, all the medications that we spoke about tonight, we say are safe during.
Right. I mean, they did a study that, you know, kids that were born when you have an inflammation, 100% of those kids become a pain in the tuchus. But I mean, that's also the case by some people that don't have IBD. So it's inconclusive, that study, really. All right, next, doctor. So someone was diagnosed with Crohn's, with fistulas. I think the main question here is, what is really the difference? And a lot of people have this question between Remicade and Humira. I know you don't like both of them.
They're essentially work by the same mechanism. They are antibodies to that compound that we mentioned before called tumor necrosis factor alpha. One is given intravenously, which is Remicade, and probably works faster because it's given intravenously. Humira is given subcutaneously, so it doesn't, the initial effect starts 4 to 5 days after administration, whereas Remicade probably starts anywhere between 1 and 3 days. They're interchangeable. The antibody formation to Remicade, because part of Remicade is a mouse protein, the antibody formation to Remicade is higher than the antibody formation to Humira. It's rare to get an injection reaction to Humira. It's common to get an infusion reaction to Remicade. But if you look at the literature in terms of its effect on fistulas and Crohn's disease, they are pretty similar both at 6 weeks and then at a year.
Interesting. Thank you.
Can I just ask, so for example, just for the sake, if you had to choose, if the patient just said, I don't know what I want to do, how would you decide which one to go for?
The way, I'm sorry, was there an added question to that on the men's side?
It was an opinion.
No, it was an opinion.
Okay.
A non-professional opinion.
You know, I think that when you have to get somebody better quickly, then I would probably prefer to start with Remicade. When somebody is sick, and of course that is loosely defined, I think that I would start with Remicade. I also think, and I don't know if everybody agrees with this, I also think that the medications that we give in ulcerative colitis, specifically in ulcerative colitis, work better intravenously than they do any other way that we give it. So that IV steroids work better than oral steroids. Intravenous cyclosporin works better than oral tacrolimus. Intravenous Remicade, when looked at with the other studies, probably in ulcerative colitis works better. So the similarity is more for Crohn's disease, and the dissimilarity is probably in ulcerative colitis. Again, that's my own opinion and may not be agreed to by anybody else on the panel.
Can I just comment? So, as I mentioned, trying to know how much inflammation a child or a patient has, you want to match the medicine. So there's just X amount of medicine in a pen of Humira. And so sometimes the sort of cleanup crew, as I tell the patients, doesn't match the mess of the inflammation. And with Remicade, we can dial up the amount we need to give so that our cleanup matches our mess. And so the Remicade allows us, at least with children, to have a little bit easier time making that proper match to get the disease under control. So it's a very limited amount of Crohn's. Then I think giving children the luxury of not having to come to an infusion center and using Humira is huge. But if you're not gonna match, then it's not right. And so Remicade becomes very useful in that way. And there's just a certain amount of pens that we can give to a child that, you know, wasn't approved for more than 1 pen per week, to my knowledge. Do you ever give more than 1 pen a week? But it's difficult to obtain, and it also hurts. So for a lot of the children, it feels better with Remicade rather than the injection of of the pen. So sometimes that comes into play also.
All right, it's getting late. I'm sorry about that. We're not going to be able to get to all the questions, and I'm just going to wrap up here with 2.5 more questions here. This question here is for Dr. Lawlor, and we promised to talk about this. And how effective is a doobie?
It was actually interesting because you brought that up. So you went to California and you were there for 2 years?
No. 2 years remission. I was there for like 8 years.
All right. Okay. So cannabis is now available as medical marijuana for the management of specific diseases such as cancer-induced pain, multiple sclerosis, Crohn's disease, and also colitis, in I think 27 states. So it's very widely available, and most recently became available for recreational use in Massachusetts. I think California now.
Yes.
I can't remember.
Yeah.
Washington, Oregon. So it's becoming
He's
very
moving
widely
back to
available.
California.
I left, and then they voted that in. I'm like, wait a second.
So yeah, and I think it's a very, very important thing to discuss because we need to dispel the stigma associated with cannabis. I mean, I'm not suggesting I'll go out and blaze doobies, as you would say, but it is something that has been looked at in studies in inflammatory bowel disease as well. So just to kind of give you an idea, so there are things called cannabinoids. They are these plant-based molecules. They're all very structurally similar. One of them is called THC, which is what's in cannabis. So it's a psychoactive drug. It makes you feel high. It's amazing, I hear. I don't know. But there are 17 other forms, and they appear to have some sort of anti-inflammatory effect. There's one specific cannabinoid called CBD or cannabidiol that's been shown in lab studies to be effective in reducing inflammation similar to colitis and Crohn's disease. So there may well be something there, and people are still looking into it. We don't have any good human trials in cannabidiol, but we do have clinical trials in THC, which is the street drug cannabis, and it was shown to be effective in helping your symptoms. So for abdominal pain, diarrhea, bloating, feeling crappy, and so on, it's been shown to be effective. But again, it's like the two parallels of treating the symptoms and treating the disease. There was no evidence that it actually treated the disease. So personally, I've used it for 3 patients, and the 3 patients were exactly the same. They were very, very sick. They were in my clinic room, and they were on the verge of having to go to the ER. They were that sick, and we were going to start a biologic, but we didn't have time for the biologic to kick in, because they could kick in, it could take 4 weeks to kick in. So these 3 patients started cannabis that day, and it was extraordinary, because it helped them avoid coming to the emergency room. It reduced their abdominal pain, it gave them their appetite back, it reduced the diarrhea. It was a perfect bridge for the therapy of these patients and getting them better enough to allow the drug time to kick in. So I'm actually a fan, but it's not something that is a prolonged therapy. It's for that acute setting where you want to get them better enough to survive the symptoms before the actual drugs can kick in. That's how I use it.
And you always gotta keep the right munchies around, or else you could keep the popcorn away, the fried munchies.
Well, that's something I didn't kind of explain well enough. So there are a number of cannabinoids. So if you want to kind of just use the street drug, the THC, it'll make you feel better and so on. But now these days, the doctors that there are doctors out there that prescribe it, and they can prescribe different variations of it. They can prescribe so 15% is usually what for street cannabis is 15% THC. So it's the psychoactive component. But now people can prescribe in the marijuana stores, whatever you call those outlets, make them 15% CBD and 3% THC. So it'll give you a little bit of a calming high, but also will have that anti-inflammatory effect of the CBD. We don't have the evidence that CBD works, but I think that's something that eventually we're going to be learning in the next couple of years.
All righty. Looking forward. For now, there's oxycodone. That also gives the same effectiveness. No,
we don't like that. No.
Oh, okay. I like it a lot. If only they could come up with something like that that's just safe and lasts forever, Okay. Rebitson, this is for you. The question is, there's a very concerned mother that has in her family a lot of different members that have IBD. And she's wondering about her 1.5-year-old daughter. Sees in the pamper tomatoes, mango, watermelon, and a lot of stuff like that. Is that normal? And I think it's good to relate this to another question: is if you have it, if it runs in the family, at what point should you or should you at all screen the child at a certain age to see if something's going on?
It's normal to see those foods in the diaper, that's normal. As far as screening, as long as the child feels good and is gaining and growing and thriving, there's no reason to assume that a child in a family with a lot of IBD will get IBD. There is a study that we're doing looking at families where there are a lot of members within an immediate family. So if there are 4 or 5 people within one family, so 4 out of 8 siblings, let's say, have Crohn's, to try to see if there's something we can understand about the microbiome, the bacteria that makes up their intestines, and if we can see if there's a difference between the microbiome in the children who have IBD versus those that don't, and if we could test their stool all along and see if there's all of a sudden a shift in their microbiome, and if we could somehow prevent things. But this is very, very, very early, and that's for an immediate core family, not an extended family with cousins and grandparents and that kind of thing.
Thank you very much. I just want to remind everyone that to put their email address when they leave so we can continue this going to support each other. I'd like to give a big round of applause, a huge thank you for all our doctors here tonight. And I'd also like to give a huge thank you to Eli Drummer for putting this event and lots of events together. And I hope everyone should feel good, or if it's your loved one or someone you know, we should all feel good and be with Mashiach Tzidkenu and not have any of this stuff. Thanks for coming, guys. Thank you very much.